may I ask Ma'am Sylvia to lead us on prayer? Ma'am Sylvia.
Yes, let's bow down our heads and pray in the name of the Father, the Son, and the Holy Spirit. Our Heavenly Father, we praise and honor you. We believe that as we enter a glorious new year, it is to be filled with prayer and praise, with service to God and our countrymen, with renewed hopes for better days ahead. We thank you for your presence that goes with us in our meetings, in our activities, virtually or otherwise. We believe your love will transcend our iniquities, your wisdom will guide our decisions. We thank you, Lord, for your blessings, dear God, for all that you do despite our frailties. You alone deserve all praise. In Jesus' name we pray. Amen.
Amen. This meeting is now called to order. May I hear a motion, Kong Jun Gato?
Madam Chair, I move to dispense with the calling of the roll. I so move, Madam Chair.
I second the motion, Madam Chair.
There's a motion to dispense the calling of the roll, duly seconded. Is there any objection? Hearing none, the motion is approved. Before we proceed, I'd like to recognize first the presence of the following members. We have with us Representative Jun Gato, Representative Adrian Ebcas, Representative Bobby Pacquiao, Representative Rodolfo Ompong Ordonez, Representative Gil Acosta, our Deputy Speaker, Representative Rosemary Baby Arenas. We also have Deputy Speaker Evie Escudero. We have Representative Carlos Zarate.
Good morning, Madam Chair.
And we have Representative Diego T. Also, we have Representative Stella Kimbo. Okay, we'll recognize as we go along other members. Ma'am Sylvia, can you recognize the presence of our resource persons?
Yes, ma'am. From the Department of Health, we have Yusek Mirna Kabutahe, Chairperson of the National Vaccine Operations Center. We have OIC ASEC Maylene M. Beltran. We have Director Roderick Napulan. We have Dr. Alatea de Guzman. We have Director Angelina Del Mundo.
Good morning.
And we have Julius Cesar Castillo. From the PhilHealth, we have PCO Attorney Dante Gueran. Probably in the boardroom, we have EVP COO Attorney Eli Dino Santos, SVP Attorney Jose Marie Tolentino, SVP Maria Emily Roque. We have SVP Attorney Angel Miranda, SVP Dr. Clementine Bautista. We have SVP Dr. Arturo Alcantara. We have SVP Nerissa Santiago, and PHIC Geneve Masahud. From the Commission on Audit, we have Rodora F. Ugay. We have Mirna R. Marcelino, Audit Team Leader. We have Maria Carmelita Enriquez, Supervising Auditor. We have Amelia P. Castro, Audit Team Leader. We have Ethel C. Superable, Audit Team Leader. We have Olens Joseph T. Primavera, Audit Team Leader. Cheryl A. Milano, Audit Team Leader. Abdul Nasif M. Faisal, Acting Supervising Auditor. Norma Belia F. Portiles, Audit Team Leader. Leah Pamela P. Fernandez, OIC Audit Team Leader. Alvin Anthony T. Almoradie, OIC Audit Team Leader, and Clarissa T. Mijares, OIC Audit Team Leader. From the Anti-Red Tape Authority, we have Yusek Carlos Kita, Chief of Staff and Deputy Director General for Admin and Finance. From the Philippine Medical Association, we have Dr. Benito Atienza. From the Association of Public Health Maintenance Organizations of the Philippines, or AMOF, we have Mr. Carlos D. De Silva. From the National Task Force Against COVID-19, we have Director Carissa L. Cruz, Head of the NTF Coordinating Committee. From the FDA, we have Dr. Oscar G. Gutierrez Jr. We have Ms. Caroline P. Custodio, and Mr. Raymond L. Sia. From the DBM, we have Director Jane B. Abella in charge of DOH funding, and Mr. Jus Rex Abihero, Senior Budget and Management Specialist in charge of DOH funding. We also have Mr. Carlo Miguel Centeno, Budget and Management Specialist 1. From the PAMET, or the Philippine Association of Medical Technologies, Inc., we have Ms. Sanita Vistal, Ms. Evangeline Castillo, Mr. Mark Raymond Nava, and Ms. Sanita Agcana Vistal. From the DOTR, we have Yusek Ochi Tuason, Yusek George Ursabe Jr., Director Michael Capati, ASEC Steve Pastor, DG Sim Sing Sidyongko, and Dr. Rolly Bayaban, the CAAP Chief of Office of Flight Surgeon Aviation Medicine. From the PGH, we have Dr. Gerardo D. Legaspi. That's all, Your Honor.
Thank you, Ma'am Sylvia. Honorable members, esteemed resource persons, and to everyone joining us today, magandang umaga pong muli sa inyo. Media reports that came out last week include the news on the PhilHealth pronouncement or commitment to pay hospital claims amounting to 25.45 billion in 6 months. This came on the heels of the committee's public hearing last Tuesday regarding the latest updates on PhilHealth reimbursements or payments to hospitals, which was followed through with the previous meetings that were conducted, particularly on different PhilHealth circulars on the availment of COVID-19 related benefit packages and issue of the PhilHealth Circular 2021-0013 or the temporary suspension of payment of claims or TSPC. This hearing is a continuation of last week's agenda on the matter, especially because there was an intervening point on the inclusion of claims for confirmed COVID-19 cases based on antigen test result in the benefit package, an issue which PhilHealth President and CEO Attorney Dante Garan said will be taken up during its board meeting last week, if I'm not mistaken, last Wednesday. It was quite unfortunate that nobody from the Commission on Audit, the country's supreme state audit institution, was able to join the previous meeting. The COA had given us a better given us a better picture of PhilHealth's finances, particularly in relation to its payment to hospitals, which may also be critical in finding ways to expedite the process of hospital reimbursement other than the already admitted issue of lack of manpower complement on the part of PhilHealth and the problem on the information technology structure. The committee also wants to know COA's position on ARTA's recommendation relative to PhilHealth's backlogs in payment to hospitals and health facilities. Another follow-through is our next item, the last in the agenda for today, where we will get from the Department of Health a briefing on the current COVID-19 situation in the country, particularly on the COVID-19 Vaccination Program and the Human Resources for Health Program. We had similar briefings in 2020 and 2021 that touch on this matter, but the situation now has drastically changed due to the latest variants of concern and vaccination rate, among other factors. The DOH and the National Task Force Against COVID-19, together with other agencies of government and private sector, are here with us to keep us posted on the pandemic situation and appropriate response to address this health crisis. The committee also wishes to thank everyone for your time and cooperation as it continually seeks to champion the state principle and policy of protecting and promoting the right to health of the people and still health consciousness among them. So maraming salamat po again and magandang umaga. So we'll now recognize, since this is a continuation of the discussion on the pending or pressing issues on PhilHealth, siguro po hingan na natin muna ng presentation ang Department of Health, no? Through Yusek Mir na on the updates of the COVID vaccination program, and then Director ASEC Mylene Beltran on the updates of their Human Resource for Health program, and Dr. Thea Guzman on the updates doon po sa protocols on quarantine and isolation. Yusek Myrna, before we proceed on the interpellation sa PhilHealth, so that the members can ask questions to both PhilHealth and DOH. Yusek Myrna.
Yes, ma'am. With your permission, the Secretariat has a copy of the vaccine rollout. I
Comsec.
have a short. Yes, ma'am.
Go ahead on your presentation, Yusek Myrna. Do you have presentation?
Magandang umaga po. Yes, ma'am. It was sent to the Secretariat. Paki-check lang po yesterday.
Sylvia, paki-share ng presentation in the screen.
If there is none, can we nandyan na? Okay, si Doc Sham na.
Before you go on,
Magandang umaga.
Yusek Myrna,
Yes,
I
ma'am.
would like to recognize first the presence of the following members: Representative Princess Rihan Sakaluran, Representative Crystal Bagat Singh. Okay, please proceed. You have the floor, Yusek Myrna.
Magandang umaga po sa ating kagalang-galang na Committee on Health at lahat po ng ating mga kagalang-galang na miyembro ng House of Representatives. In behalf of Secretary Galvez, I've been requested to present the vaccine coverage in behalf of the vaccine cluster of the DOH-NTF. So as of January 16 po, we have already administered 118 million jabs. 58.8 million are first doses and 55.1 million po ang second dose. These are the fully vaccinated, including the 1-dose Janssen vaccine. Tapos nakapagtala na po tayo ng 4.9 booster or additional doses. From the start, we already had received 213 million doses of various vaccines, and 158.6 million po ang ating na-i-deploy na sa iba't ibang parte ng ating bansa. Next slide, please. In terms of the coverage by priority groups, this is already based on the start of 2022. Yung ating pong A1, yung healthcare workers, yung ating pong target ay yung anong tawag dyan, yung last entry from last year. So tumaas na po ng 2.1 million. We have given all of them at least 1 dose, 2.1 of the 2.1. And sa kanila po ay 91.9% na po ang naka-fully vaccinated. Yung ating pong expanded A1, ito po yung outbound OFWs, tapos yung ating family members of healthcare workers. And additional A1, ito na ngayon yung mga bago, mga clerks natin, mga interns natin, and then the new hires who have not been previously vaccinated. No? So nandito tayo sa 94.53% and 88.17 respectively. Yung ating senior citizens, the 60 and above, we have used now the 9.2 target population. Ito po yung medyo we need to ramp up more. 6.4 po ang nabakunahan, that is at 70, and 64.39% po ang fully vaccinated sa ating mga senior citizens. Yung ating individuals with comorbidities, we are doing well at 99.86% first dose and 92.9% second dose. Yung ating pregnant women as they come, And our children with comorbidities, we started late November. Nandito na po tayo sa 22.75 first dose and 15.57 second dose. Yung ating mga frontline personnel in the essential sector at 68.28 and 60.62 respectively. Yung ating poor population at 69.44 and 58.75 respectively. The rest of the adult population, nasa 91.56 na po ang ating first dose and 68.84 ang second dose. And for the rest of the pediatric, nasa 71.69 first dose at saka 58.44 second dose. The next slide will tell us how the coverage was done in the different regions. Can we have the next slide, please? Pinakamataas po ang National Capital Region. Ang ginagamit pa natin ngayon ay ang target population natin na 70% of the total population. Pero 2022 data na po. So NCR has 117.77% first dose. We all know that NCR also vaccinating the nearby areas. And by place of work po kasi, kung nagtatrabaho sa NCR, they can be provided the vaccine. So fully vaxxed at 108. And then ang naka-green po ay 90, Region 1 and 78 fully vaccinated. Yung mga naka-yellow po ay above 65%. So all the regions are above 65%. And mababa lang po ang BARM at 33 and 23.9 for a total of 81.59% of 78 million have already been given one dose, and 70.54% or 55 million have already been given their second doses or at least one dose for Janssen. Next slide, please. Ito naman po yung ating regional distribution from the start, from March, April, May, June, July, August, up to January 22. By regions, pinakamalaki po ang NCR at 28 million. Pumapangalawa po ang Region 4A at 23 million at pumapangatlo po ang Region 3 ng 18 million. Ang lowest po ay ating Cordillera, and BARM. So for a total of 157 million doses that have already been deployed from the start. Next slide, please. Ang ating pong 2022 objectives and targets. For 2022 po, in terms of budget and financial target for supply negotiations, all our eligible population are given vaccines with EUA with primary series and booster doses. Ito na po ay based sa ating 2022 population. So ang target po natin ay 72.1 million na adults bigyan ng booster, 12.7 million with boosters. Wala pa tayong guidelines po ng 12 to 17 years old with booster. Primary doses lang po ang binibigay, but soon we will have the guidelines out. And then we will have po the 15.56 million 5 to 11 years old with primary series. Pagdating po ng bakuna by the end of this month, we may start our vaccination of 5 to 11 years old po ng start of February. Ang approved pa lang po ng Philippine FDA na 5 to 11 vaccine ay ang Pfizer. Although na-announce po na Sinovac and even Covaxin have already applied for 3 to 11 years old. And then kung may EUA na po, and there are already guidelines abroad and there are studies, we will also start 0 to 4 years old with the primary series. So these are all in the pipeline. Pero sa ating operational target, we would like to have all the eligible population of 111 million individuals with primary vaccination series and with booster or additional doses. Ang aking last slide po ay ito po yung ating NTF Vaccine Cluster 2022 timelines and milestones. So 18 years old and above. At the beginning, we started with 52 million. We hope to achieve 77 million by the end of first quarter. And by end of second quarter, we will be able to have 90 million vaccinated, prioritizing our seniors and those with comorbidities. So that for the third quarter, meron na pong 72.16 million booster natin for our remaining population. Sa ating 12 to 17 years old, 5.2 million at the beginning of the year, and then we hope to achieve 10.2 million by the end of the first quarter, and then we will start to do the booster by the second quarter. For 5 to 11, kagaya po ng sabi ko, we will start 12.5 million vaccinating, depende po kung ano yung volume that will come. So in February, and then ituloy-tuloy po. And then later, by third and fourth quarter, we may be able to have the boosters. And hopefully by April, kung nakalabas na po yung EUA, may EUA na po sa vaccine, and we will have the guidelines already. Ang tinitingnan po natin by April, we will already have the 0 to 4 years old that will be vaccinated. Yan lang po, Madam Chairperson. Maraming salamat po.
Thank you, Yusek Mierna. Can I call on Dr. Thea de Guzman for updates on the protocols? Dr. Thea? Do we have Dr. Thea Guzman? Okay, while waiting, may I call on Asek Mierna or Mylene Beltran for HRH updates.
Sige. Baka ako na. Ay,
Go ahead.
yes, ma'am. Good morning po sa lahat. Good morning po to our representatives and to our co-workers in government and everyone po. So, ma'am and everyone, Ma'am Chair, I'll be presenting. Yes, sir. You hear me, ma'am? Am I clear po?
Yes, Asek Mylene. Go ahead.
Yes, ma'am. So,
Here, yes.
so again, good morning po sa lahat. So I'll be presenting po briefly the healthcare workers benefits update as of today po, as of January 7th po. Okay, ma'am. So I hope you are seeing my slides. So as of January 17, the DOH has already released a total amount of 16.2 billion worth of healthcare workers benefits. The total amount of 16.2 billion comprised of the following po. For actual hazard duty pay.
Asek Mylene?
Yes, ma'am.
Nawawala yung audio mo.
Duty pay,
Asek Mylene?
meron na po kaming nabigyan na 390,662 healthcare workers amounting to 6.6 billion. And yes, ma'am. Yes po.
Nagpuputol-putol yung audio.
Ma'am, do you hear me loud and clear?
Yes, yes. But nagka-cut yung audio, Asek Mylene. Can you turn off muna yung video mo?
Okay, ma'am. Ma'am, do you hear me now?
Yes, yes. Please proceed.
Okay.
ASEC? ASEC? ASEC, wala kang audio.
Ah. Okay. Ma'am, okay na po?
Okay, sige, please proceed.
Okay. Thank you ulit po. Can I just repeat po, ma'am? The DOH has already released a total amount of 16.2 billion worth of healthcare workers' benefits as of January 17, 2022. The total amount of 16.2 billion comprised of the following as shown in this table. Actual hazard duty pay, we were already able to provide 391,000 healthcare workers, and as well as for the special risk allowance of for September 20 to December 19, 2020, we already provided 315,652 healthcare workers. So yung amount po is amounting to 6.6 billion pesos. 6.6 million pesos po, 6.6 billion pesos. For SRA ho, for December 20 to June 30, 2021, again, we were able to provide 496,314 healthcare workers, amounting to around 8 billion po. For MAT, in 2 tranches po, we were able to provide for the period September 20 to December 19, 2020, a total of for batch 1, 103,413 healthcare workers, amounting to 1.2 billion. And then for batch 2, which was released this December, we were able to provide 106,115 healthcare workers, amounting to 401,771. So for life insurance enrollment po, we were able to enroll 32,281 healthcare workers, amounting to 16 million pesos po. So this is as of January 17. So for the details of the special risk allowance, as I've mentioned earlier, we have provided a total of 7.88 billion na lang po to round it off, to around 496,314 healthcare workers. Ito po yung details ho, per batch, and the amount allotted, amount disbursed directly to the healthcare workers, and it's already in the account of the healthcare workers. And ito po yung last column, yung number of healthcare workers provided. Yun po, ma'am. And then, again, this would cover po the period from December 20 to June 30, 2021. Next, please. We have an additional request for special risk allowance po, amounting to 3.3 billion pesos, and to cover the special risk allowance po of around 185,000 healthcare workers. So ito po yung per batch na naatado ho namin. So batch 4, we have requested the amount of 1.1 billion to cover an additional 59,697 healthcare workers. Batch 5 is in the amount of 1.5 billion to cover an additional healthcare workers as validated eligible to receive SRA by our operating units, and this would be around 80,000. And for batch 6, again, we have also processed and requested the amount of 704 million to cover an additional 45,394 healthcare workers po. As of now po, we've made representation to the DBM. We're working it out with DBM po kasi we're also trying to review the savings that we can use from our 2021 budget para ho ma-defray namin po yung amount for this special risk allowance. And we're closely working po with DBM on this. Next, please. So ito naman po yung MAT benefits. We were able to secure an additional 1.5 billion from the Office of the President Contingency Fund last December. And we are processing up to now from covering the period po from September 20 to December 19, 2020, an amount we have already allotted 976 million, and we already have disbursed again to the healthcare workers na 402 million, this is the amount pala, 402 million or around 41.17% of our allotted amount to a total number of 106,115 healthcare workers. Ongoing pa po yung ating pagdidistribute ng MAT to our various operating units as of today. Yun po, mga ating mga kasamahan po dito, our House of Reps, our representatives, yun po yung mga benefits that we already have provided. So for this po, we have already hired for this year a total number of 4,123 various healthcare workers to again be an augmentation to our various operating units nationwide. So this is just 57% of the total approved slots for HRH hiring. So ongoing pa po yung request ng ating operating units, and we are processing po additional requests from other regions nationwide. We also have considered po dito pala yung the needs for the emergency hires due to the Typhoon Odette, specifically in regions 6, 7, 8, and Caraga. Yun po. Next, please. Yun po ang aking mga information to share as of this time, Ma'am Chair. Thank you.
Thank you, Yusek Mirna. Ready na po ba si Dr. Thea Guzman?
Madam Chair, good morning. Apologies
Morning.
po. Yes po. Madam Chair, I will be, I was just informed that we will also present updates on isolation and testing. But before that, if I can briefly give the national situation report. No? So we'd like to present to our honorable members these key messages that we have now observed an increase in cases across all regions and all provinces, highly urbanized cities, and independent component cities. But there are still areas whose counts are lower than what we are seeing now in the NCR+, but we're already seeing continuous and swift increases. The increase we saw in NCR+ is much larger than the peak we saw in September 2021 in relation to Delta. But what we observe is that our hospitalization, as well as the number of severe and critical disease, were less than what we observed last year. We also noted that the percent severe, critical, and fatalities have been continuously declining in 2020. And in the National Capital Region, where we have the largest vaccination coverage, the actual counts of severe and critical, as well as fatalities, have actually also reduced. And lastly, we'd like to relay that these case increases that we've seen, especially in the National Capital Region, is driven by Omicron, but is also facilitated by our increased mobility, our reduced compliance to minimum public health standards, as well as delays in our detection and isolation. As such, our recommendations and response are to mitigate these case increases through immediate isolation and quarantine, thus the changes in our protocols and also the consistent practice of MPHS. But vaccination will play a big role in reducing severe critical cases as well as fatalities. So just to quickly, we'd like to relay that our latest whole genome sequencing showed that the Omicron variant is now the predominant variant in the National Capital Region, It's also detected in 13 of 17 regions, and in the National Capital Region, 15 of its 17 areas already have local Omicron cases. One of its effects is this very large number of cases. Number one, we already saw the number of cases observed in January 2022 to be higher than our actual peak in September 2021. And if you noted in this graph, each peak that we have throughout this pandemic is larger than the previous peak. Also, this is our largest and fastest increase since the start of the pandemic. And we'd like to note that while the increase has slowed down, we are not yet seeing any decline in our cases. This increase is observed in all island groups, but it's NCR, the blue line, NC, the plus areas, the green, and the rest of Luzon, red, which are now showing the fastest and largest increases. Currently, nationally, we are critical risk case classification po, with a 2-week growth rate of as high as 1,805%, and our average daily attack rate is now at 24.82%. However, nationally, we're able to maintain a low-risk total bed and ICU bed utilization. There are 6 regions also at critical risk, and that includes NCR, Calabarzon, and 3, with NCR having an average daily attack rate of 103.59. There are 5 regions whose total bed and ICU bed utilizations have already increased beyond the 50% threshold, and that's NCR, Regions 2, 1, Calabarzon, as well as Region 5. We're just showing here, Madam Chair, that as per our alert level system, 99 or 82% of our provinces, HUCs, and ICCs are now under alert level 3, the rest being under alert level 2. However, we'd also like to share that despite this large number of cases, what we saw is this orange line showing our percent severe and critical, that it's not proportionately or increasing equal to what we saw to our cases, as well as the deaths below, where we did not see an equal or proportionate increase in deaths as of date. We'd also like to share that as of January 2022, 75% are mild and moderate, and 13% are asymptomatic cases based on our admission data, and only 12% are severe and critical. And lastly, we'd also like to put emphasis that based on our data of admissions, a larger percentage are actually the non-fully vaccinated. Among our admitted, 84% are those not fully vaccinated. And among deaths and admissions, 92 or almost 93% are those not fully vaccinated. As such, our analytic studies are showing that those who had severe and critical disease and those who became fatalities among our admissions are the ones most likely to be not fully vaccinated. I will go on now to the updates of our isolation and quarantine protocols. And this is the base and the basis of these changes in protocols. One, we do know that vaccines continue to protect against severe disease and death despite the emergence of these new variants. We do note that there is this Omicron leads to increased transmissibility, but it seems to be associated with less severe disease, with hospitalization reduced by 1/3 compared to Delta, and also lower in-hospital deaths and shorter length of stay. As such, we'd like to share these updated protocols on isolation and quarantine. So number one, we shortened the length of isolation. It's the same for our general public and our healthcare workers. The difference would be that our healthcare workers may further shorten this isolation protocol or length depending on the Infection Prevention and Control Committee standards po. So we have just relayed here the difference between fully vaccinated versus those who are partially or unvaccinated. So for those who have symptoms or who have been a confirmed case but have mild disease, for the fully vaccinated, they can do a 7-day isolation starting from onset of symptoms, But for those partially vaccinated or unvaccinated, their isolation is a bit longer at 10 days. We observe the same length of isolation among those who are confirmed case but are asymptomatic, but the difference is the reference date is 7 days from date of test for the fully vaccinated and 10 days from the date of test among those who are partially or unvaccinated. And lastly, for confirmed cases presenting with moderate disease, they need to do a minimum 10 days of isolation from onset of symptoms. They may be discharged or tagged as recovered if at the end of these isolation periods, they have either remained asymptomatic or have been assessed to be clinically recovered by their physician or healthcare worker, and there is no retesting required prior to discharge. For our isolation for severe cases, it's at the minimum of 21 days from onset of symptoms. However, for those who are confirmed cases but have been assessed to be immunocompromised, other than the minimum 21 days of isolation, they need to have a negative repeat RT-PCR at the end of their isolation. Going on now to our quarantine, and we'd like to emphasize that this change in quarantine protocol is only for asymptomatic close contacts, where starting January 13, those who are fully vaccinated only need to undergo a minimum of 5 days of quarantine. And for those partially or unvaccinated, they still have to undergo the 14-day quarantine. This reference date for this is the date of their last exposure to a suspect, probable unconfirmed case. Throughout the quarantine period, they need to symptom monitor even up to 14 days. They need to ensure that they are consistently and correctly wearing their mask, and they should be strictly adhering to minimum public health standards. For the healthcare workers, they can undergo 5 days of quarantine, but again, as per the assessment and standards of their hospital's Infection Prevention and Control Committee, or as set by the provincial and city health officers of highly urbanized independent component cities, they can further reduce this number of quarantine days po. And as to our testing, these new testing protocols are as follows. We need to prioritize the testing of our A1 or our healthcare workers to ensure it's a surveillance testing to ensure that we will have adequate staff and health human resources as support to our health system capacity. We also need to prioritize A2 or A3 or those with comorbidities, given that the confirmation of COVID-19 will determine if investigational drugs can be given. However, for those without symptoms or those only without symptoms, but not among the A1, A2, A3, this is optional, and the advice given is to already isolate. Once either you become exposed, test positive, or once you become symptomatic. So lastly, Madam Chair, we'd just like to share these updated messaging, and we'd like to also provide direction that what we'd like to see from the workplace is that previously we would need repeat RT-PCR. Some employers would ask that. What our recommendation is to already provide instead certification from a physician or the LGU in lieu of a test result. For our PhilHealth reimbursement, there's ongoing coordination with PhilHealth so that they can update their benefit package so that this can adapt to our new policy directions. We do know that our testing protocols, the new testing protocols, will have impact of our case numbers, and we are actually planning already a transition from counting all confirmed cases to a more sentinel-based surveillance system, and to provide more focus on severe and critical, as well as our health system capacity. And lastly, for contact tracing, we'd like to relay that in areas where there is wide-scale community transmission, contact tracing may not be our priority or primary intervention, rather to expand already their job description to include monitoring of cases under isolation or quarantine, adherence to MPHS, assist in our vaccination deployment, in health promotion, and other non-COVID work. Again, Madam Chair, this is only for areas with wide-scale community transmission, but in areas where there's still few cases, contact tracing, intensified contact tracing has value. So we'd like to end with the summary of key messages that number one, because our vaccination efforts have already significantly reduced our chances of getting severe disease and becoming a fatality, these policies and guidelines have been updated so it reflects the current evidence base as well as achieving a more favorable risk-benefit ratio. We also know and continue to emphasize that vaccines prevent severe disease, and there are new drugs, interventional drugs, that we can rely on so that we can minimize risk among the most at risk or who are unvaccinated. And even with our large case increase, there are benefit of vaccine, and the features of Omicron make us confident that number one, we can shorten our isolation and quarantine. Number two, we can reserve testing as assessed by our physician to be necessary for medical management. And number three, to make testing optional when our actions will be the same regardless of the result. And lastly, we'd like to continue to emphasize the need to still practice MPHS, even if we did note shorter infectivity and milder disease among our vaccinated and boosted. So that's all, Madam Chair. Thank you very much and a good morning.
Thank you, Doktora Thea. Anyone from DOH? Meron pa pong mag-present ng updates? If none, I would like to call on the director of or the medical center chief of the Philippine General Hospital, Dr. Gap Legaspi, for an update. Doc Gap. Director Legaspi. Ma'am Sylvia.
Ma'am, I will try to contact him.
Director Gap. Director Legaspi.
Yes, good morning, ma'am. Sorry. Yes.
Okay po. Can you give us updates, sir, on the situation, at least sa PGH?
Thank you, ma'am. Thank you very much for this chance to share our experience here. I think the presentation of Dr. De Guzman reflects what's happening in a lot of hospitals. We have observed a marked increase. It truly is a record admission also. We're now at almost 360 patients compared to our highest of 310 last time. But what we're seeing is that compared to the September surge of Delta, where we had 65% of them sick of COVID itself, now only 12% are actually sick of COVID, meaning with pneumonia or severe COVID from the infection itself. What is happening now is that there are more patients with sick of other diseases like a heart attack or stroke or head injury or ruptured aneurysm or other diseases who incidentally have COVID infection. So that's why that explains probably for the data that those needing ICU care because of COVID, severe COVID status are much less now. They're needing ICU care because of stroke or heart attacks rather than the actual COVID. So I think the reflection of the effect of of the vaccination also on the severity of COVID manifestations is experienced in our patients as well. So I think the most telling difference between the crisis of September and now is that the lack is not anymore high flow nasal cannula or respirators. No, when we had to decide who will get the last one and who will die or not in the ER, it is more of the effect on the COVID on the healthcare workers. So I think we were decimated. Most big hospitals had 50% reduction because of COVID infection, and we were really thankful for the timely announcement of a shortened quarantine period by the Department of Health, which helped a lot in bringing back our healthcare workers. So we continue to increase in COVID numbers every day in admission, but I think it's more manageable now than before. So I still recommend that we continue with our vaccination program aggressively, because I think this is also one game changer in the whole drive against COVID.
Director, sa
Yes.
PGH po, yung healthcare workers natin, ang protocol 5 days ang isolation, right? And no quarantine requirement for those close contacts. Do you require repeat RT-PCR after 5 days for those infected?
Those infected, ma'am, no, we just follow the protocol as recommended by DOH. We don't repeat the swab test for our COVID infected, COVID positive healthcare workers. But I think we count them a day after they start. So we generally it's 8 days when they come back rather than 7. Pag binilang talaga 8 days siya. But the high exposure, high risk exposure, yung mga contacts of COVID positive, they don't quarantine anymore. As long as they're asymptomatic, they continue to work. Those that we have doubts, we test on the 5th day. And meron po ho nagpa-positive kahit papano, pero much less than the average of around 45% positivity. So meron pa rin hindi dinagdag na konting safety measure doon sa mga exposed but asymptomatic. But the positive ones, hindi na po. We just follow the 7 days and then ask them to come back already.
But how's the status ng ating mga healthcare workers? Marami pa rin pong infected as of the moment. Mga ilan po ang affected?
Bumaba na po. I'm going to give you, mula po ng January 3, nag-umpisang mga 100 a day po ang nagpa-positive sa amin.
Okay.
Hanggang this weekend, when we started a decrease of around 50% already. So bumababa na po yung mga healthcare workers na infected. We actually reached 1,100 plus already of the 2,800 that work in the COVID in the hospital clinical areas. So and the malaking difference po ngayon, wala pong na-admit, siguro 3 lang po ang na-admit in the early part, but in the last few weeks, the last 2 weeks, wala na pong na-admit na healthcare worker. So malaking difference po talaga compared to before. We used to have an admission of around 30% of healthcare workers that needed admission in the hospital. But for now, 3 lang po yata of the 1,000 plus admit.
Director, pedia patients, do you encounter increased admissions of pedia patients with COVID?
Yes po, yan po yung napuna naming malaki ngayon. In fact, we have from a previous bed of 15, ngayon po ang pedia patients namin 35 na.
Mm-hmm.
So we had to increase our pedia cases for 2 reasons. So one, ang napuna ho namin, yung mga batang may sakit na dati, lalo pa sila nagkakasakit pag nag-COVID. So these are those with pre-morbid conditions, mga may heart disease, congenital heart problems, congenital brain problems, mga may infection of another type or may mga leukemia, no? Mga ganun po. And the other one is we also have a very high COVID positive obstetric admission. Mm-hmm. So that makes our nursery babies high risk also. So we had to add more beds for our babies being born to COVID positive mothers. So from mga 15 at the highest, we're up to 35 now at dumadami pa po. I think it will reach mga 50 all in all beds that we prepare.
Thank you. Thank you so much, Director, for sharing the PGH experiences on this current surge on COVID. Maraming salamat po.
Thank you, Congressman. Thank you very much.
One from DOH po, meron pang magsasalita. If none, I can start the questions to PhilHealth again. To our members who wishes to ask question, kindly provide us in the chat group or in the thread, Committee on Health thread po. Pwede po kayong mag list doon sa list of names to ask question. For PhilHealth, Attorney Dante Garan, our PCEO. Do we have President Garan?
Good morning, Madam Chair. I'm present,
Morning,
Madam
sir.
Chair.
Sir, pasensya na po kayo kasi hindi pa rin ako makaget over dahil hindi straightforward yung answer nyo from my last question about the coverage ng probable claims based on your circular, PhilHealth circulars that you provided, no? Kasi I've heard from most of the hospitals, ang karamihan ng mga pending claims nila within the coverage of these circulars because of the confusion or fear of our evaluators or RVPs on paying based on the definition you provided in the recent circular on probable case. So I just want to clarify, Attorney President, on the COVID-19 packages, if this is the correct period of applicability of benefits, sir, okay? April 15, 2020 to June 18, 2021 kasi may huli po kayong inilabas na advisory that covers November 26 to June 18, 2021. So, ang eligibility po ba nito confirmed and probable COVID-19 and ang PhilHealth benefit is COVID-19 benefit package? Kasi kaya itinatanong ko, sir, anong mangyayari doon sa mga probable cases from April 15, 2020 to November 26, 2020? Okay. Another period po, meron kayo June 19, 2021 to October 31, 2021. Eligibility, ang cases managed as COVID-19 but with negative result, wherein ang coverage nito for PhilHealth benefit, intermediate package. Okay? Then June 19, 2021 onwards, you have confirmed cases only, and then the PhilHealth benefit is COVID-19 benefit package. And you have June 19, 2021 onwards with negative RT-PCR, applicable naman po ang all case rates. Okay? So, yun po yung gusto kong itanong sa inyo. Doon sa recent circular, ano pong mangyayari doon sa April 15, 2020 to November 26, 2020? Mr. President, kasi ang confusion, you have an attached in Annex B ng circular on the case definition ng DOH for suspect, probable, and confirmed COVID-19 case. At makikita po natin ang pagkakaiba. So yung first definition ng probable case, ito po yung definition nyo. It is defined as suspect case who fulfills any one of the following. So suspect case, this is for the information of our colleagues, no? suspect case whom laboratory testing for COVID-19 is inconclusive. Suspect who underwent testing for COVID-19 but not conducted in a national or subnational reference laboratory or officially accredited laboratory for COVID-19 confirmatory testing. And number 2, or suspect case for which testing could not be performed for any reason. And then, sa PhilHealth Circular 2021-0020, you defined probable case as a patient who meets clinical criteria for suspect case and is a contact of probable or confirmed case or epidemiologically linked to a cluster of cases which has at least one confirmed case identified with that cluster. Number 2, a suspected case with chest imaging showing findings suggestive of COVID-19 disease. And number 3, a person with recent onset of anosmia or loss of smell or nausea, loss of taste in absence of any other identified cause. And number 4, death not otherwise explained in an adult with respiratory distress preceding death and who was a contact of a probable or confirmed case or epidemiologically linked to a cluster which had at least one confirmed case identified within that cluster. So, can you give me a clear answer, sir? Kasi, based po doon sa feedback, kung titingnan natin yung definition po ng DOH which you adopted in that circular is mas clear, no? Mas malinaw. Ngayon, may mga series of circulars po kayong idilagay with coverage, no? Ng admissions. So, gusto po nating linawin ano po talaga na ang i-apply natin na definition ng probable case, Mr. President. So, ang tinatanong ko po yung April 15 to November 26, 2020.
Good morning, Madam Chairwoman, Congressman Helen Tan, and of course, the rest of your members of the Committee on Health and fellow government workers in attendance right now, including, of course, the Philippine family. Binabayaran naman po talaga ito noong una, Madam Chair. No? But there seems to be what we call this, humina ang bayad dito after a case was, or cases were filed against PhilHealth officials and including also the officials of the 3 hospitals in Cebu. So this case was, this matter was lagi pong sinasabi ni Dr. Almora na kaya daw humina ang pagbayad ng PhilHealth dahil sa kaso na yon. So gusto kong linawin po, Madam Chair, na yung kaso po na pinail po ng NBI against mga kasamahan natin dito sa PhilHealth involves cases not basically about, not purely about what we call this problem about interpretation of the policy. But talaga may problema, no? May isang kaso dito po na there was a falsification involved, falsification of the pirma ng doktor, and that's why the NBI filed a case on this against official of the hospital and allegedly introducing of the PhilHealth.
Mr. President, if I may cut you lang po doon sa inyong statement on the case of Cebu. So, you denied that one of the causes ng kaso na na-file po doon sa ilang personnel from that region is because may binayadan sila which turned out to have a negative result in the COVID testing. Hindi po 'yun ang rason.
Yun ang rason po na bumagal ang pagbayad po because of the cases that were filed against PhilHealth officials and officials of the hospital, Madam Chair.
Okay, sir. Ang kaso kasi mini-mention nyo kanina is due to falsification. But based on the information I gathered, may mga regional vice presidents were saying na sa mga hospitals po natin ito, pag nag-i-inquire po sila, bakit ba hindi nyo bayadan yung mga from 2020 pa? Because of that confusion, kaya nga po in all of our meetings and up to this date, today, I'm still asking you on that definition kasi may fear ang ating mga evaluators of paying based on that previous definition of probable because a mere existence ng negative result on COVID testing, madi-disqualify na at madi-deny na yung claims ng ating mga hospital. Ang problema, mas madaling mag-deny kaysa magbayad kasi masasubject sila doon sa investigation and later on, pwede silang ma-file ng case, no? Yung mga employees po ng PhilHealth. So yun po yung gusto nating i-clarify from you kasi yun po ang feedback. Ito ang naging dahilan dahil doon sa precedent case na kinakatakot ng maraming employees ng PhilHealth. Based on the mere definition nga nung probable case and the recent change on the definition of that probable case. So, nag-slow down ang payment kasi mayroong fear, number one, ang inyong mga evaluators and I don't know the RVPs kung ganun din, na bayadan dahil nga doon sa precedent case ng Cebu. Tama, sir?
That's right, Madam Chair.
So ano ang action po ng PhilHealth? Kaya po binalikan ko yung tanong kasi I think kung maglabas po kayo ng clarification doon sa circular, kasi ang ginagawa nyo po, nag-change kayo ng period, like ang admissions from June 19 to October 31, June 19 onwards. Ano po sa tingin nyo ang makakapagpabilis para mawala yung takot ng ating mga employees or evaluators and RVPs in PhilHealth? Kasi I think ito ay malaking magagawa kung once and for all, i-clarify nyo na po. If you want to adopt the second definition, then adopt it, but be definite on the period from June 15 ba yan 2020 magsisimula up to the present. So I think yun ang nagiging problema nila. May mga nabayadan na po kasi sila, then biglang it turned out negative pala. So ang mangyayari, makakasuhan talaga sila kasi sinabi doon sa inyo pong definition, dapat kung negative, hindi mo siya babayadan. So ano po ang dapat gawin talaga para ma-address yung problema na yon?
Okay. Madam Chair, maybe you are referring to PhilHealth Circular number 2020-009. Am I right?
Yes, sir. Yun po yung binasa ko kanina na definition niyo po ng probable compared po doon sa second definition natin. Kasi dito, yung nasabi, yung kaso po sa Cebu, meron silang binayaran in 2020 na it turned out negative po yung result ng COVID tests. Pero nabayadan na po because the result came out at a later date. No? So, ito yung nag-start ng fear sa ating mga regions for processing or paying etong mga pending claims na to?
Madam Chair, with respect to these cases, defensible naman po eh. Defensible naman po ang ating mga tao sa PhilHealth. Kaya meron kaming iniisip na to issue one is to issue advisory. Another one is we will issue a circular amending an earlier circular, or maybe a payment outright depending upon the opinion of our legal. We have referred that our legal, and so pag sinabi ng legal namin na base sa circular, babayaran na po natin, ibig sabihin, bayaran actually kaagad yan, no? Pero tama naman yung ginawa ng mga tao natin. Defensible po yun. Kasi ma'am, if you, this is very technical, no? I'm not like you, Madam Chair. I'm not a doctor. No? Meron dito sa nasabing circular. The intention ng circular is to pay, no? To pay both probable and confirmed, no? Yung sinasabi ng probable in the layman's term, kahit na negative, no? Kahit na negative, if the patient is managed under the COVID protocol and there are symptoms that would indicate that there was COVID, there was contagion of COVID, then it has to be paid, no? So, yun nga ang naging ng mga tao natin eh. Pero sa totoo lang ma'am, I have reviewed yung ng NBI. It's really defensible. And as a matter of fact, with respect to other circulars or other cases starting from November 26 onwards, we already issued the clarificatory memorandum on that, Madam Chair.
Yes, sir. Na-discuss po natin yon. Ito na po yung kinaklarify ko sa inyo na in-issue nyo ng which has that coverage of November 26, 2020 to June 18, 2021. So, again, sir, i-reiterate ko from the very start na tayo po ay nagkaroon ng hearing. Ito po yung pinapaklarify namin dito sa Committee on Health, no? Which has a huge impact on the hospital operations, no, because of the delays of your payment. Because yun nga yung inamin nyo naman po kanina, isa ito sa naging dahilan ng delays, no, because of that case that happened in Cebu. So siguro wala lang makapag-attest sa atin from one of your employees or regional vice presidents, but marami po, yan po yung feedback from the hospital groups. When they ask the mga RVPs, yan din yung sinasite nila. Kaya once and for all, at sa central office naman po nanggagaling through the board resolution, once and for all, i-clarify nyo na po yung definition na yan. Ano ang i-adapt ninyo from the very beginning, and consider po yung recommendations of the hospital groups, no? So, beneficial to both, to the hospitals and of course, to the PhilHealth, no? Yun naman ang sinasabi po palagi ng Committee on Health. So, we're expecting, Sir Attorney Geran, that you'll work hard po. Nakita naman namin ang mga updates on your circulars. But the Committee on Health ay hindi po titigil doon sa pagtingin kung ano ang tama sa tingin namin na makakatulong po sa both parties, no? Regarding, sir, moving on, sir, hihintayin po namin anong naging action nyo talaga dyan sa confusion na yan on the definition and coverage of the probable cases. So yung DCPM na pag-usapan natin last week, ano po? At sabi niyo po ito yung one of your strategies na makatulong sa mga hospitals. So I read yung recent po ninyong circular on DCPM. This is DCPM number 3 na po ba ito? Yung pinaka-recent?
Madam Chair, it's DCPM 3.
Opo. Napansin ko lang doon po, meron pala kayong nakalagay on item number 2, objectives. Meron po ditong nakalagay na statement, this will not apply to in-process claims already approved for payment for received claims starting February 1, 2020 to August 21, 2021. So ang coverage po ng DCPM is from DCPM 3 ay ano pong period?
The coverage of DCPM 3, of course, it follows two other DCPMs. After DCPM 1, DCPM extension, and the other DCPM 2. And so it covers the DCPM 3 now, which is nationwide. It has the application of being a nationwide application. Covers DCPM 3 covers now
February 1, 2020 to August 21, 2021. Okay, so eto po, nasa screen po. So ang coverage, ang nakalagay po dito, applicable February 1, 2020. So alam natin, dyan po nagsimula talaga yung COVID natin. To August 21, 2021. Sir, ang question ko, bakit po meron kayong applicable period? Mga in process po ito. So kung tingnan po natin, that's beyond 60 days po based on your processing of claims. Can we ask na lang po, Attorney Santos? Attorney Santos, ang question ko, why do you have applicable period po na February 1 to August 21, 2021? Bakit po hindi lahat ng in-process na COVID claims ay i-cover natin? Lahat po ng in-process. Ano po ang naging basis bakit February 1 to August 21?
Good morning, honorable members of the committee. Good morning. Madam Chairperson, the reason for this date is that this is a measure to address the plight or the situation of the hospital during the pandemic, Madam Chairperson, honorable members of this committee. That is why the period started from February 1, 2020 until August 21, 2021.
Sir, nasa pandemic pa rin po tayo hanggang ngayon. So, I was informed, marami sa ang bulk po ng mga admissions din on COVID-related din na hindi bayad is beyond August 21, August, September, October. So, bakit hindi natin kinover, sir, ang up to December 2021? Bakit kailangan nyo pong i-cut off?
Madam Chairperson, if I may, Attorney Santos. Madam Chairperson, the reason is that we have this cut off until August 21, 2021, is that by August 2021, the following day, Madam Chairperson, honorable members of this committee, we already implemented the policy on pay whichever is lower, meaning we pay depending on whichever is lower of the all pays rates or based on the statement of account. So, Madam Chairperson, we need to compute the estimate amount for these claims for the in-process. So,
Attorney Santos, okay, nag-start po yung pay whichever is lower August 21.
August 22, 2021, Madam Chairperson.
22, okay. Sige, go ahead, sir.
So, Madam Chairperson, we need to have a basis for the estimated amount of the DCPM starting August 22, 2021 and onwards. At present, Madam Chair, we already had a study on this, and in fact, we already presented the same study to the management, and that is, we call it, Madam Chairperson, the DCPM-4. So this will address the claims starting August 22, 2021 until the present, Madam Chairperson. So we are,
Also, you'll have another circular on DCPM. So meron na kayong DCPM4 naman.
Madam Chairperson, if I may, we are studying, Madam Chair, the implementation of DCPM-4, and this will cover again those in-process claims starting August 22, 2021 until the present, Madam Chairperson.
Thank you, Attorney Santos.
Very welcome, Madam Chairperson.
So currently, as of today, ilang hospitals na po ang nag-apply ng DCPM-3? Overall, in the Philippines.
Madam Chairperson, if I may, Madam Chairperson, we have received 270 letter of instruction, a letter of intent, Madam Chairperson, and we have approximately paid 77 healthcare providers.
So ilan po ang private hospitals out of 270 plus that applied?
Madam Chairperson, please give us the opportunity to gather the data on that, Madam Chairperson. We will provide it during the same hearing, Madam Chairperson.
Sige, attorney. We'll wait ha. Kindly provide us. While waiting, can we ask, do we have COA? Ma'am Sylvia, sino ang sasagot sa COA? COA? Any representative from COA? COA?
Hello, good morning, Madam Chairperson.
Yes, sir.
Chair.
Can,
Yes, good morning. This is Mr. Faisal, the current acting supervising auditor of PhilHealth from COA.
Okay. Sir, meron lang akong few questions. If you can briefly present your findings on the growing concerns on the implementation ng COVID-19 benefit package.
Hello, good morning again. Our findings on the COVID-19 package is already stated in our annual audit report, and it's already published in our COA website. So we don't have the presentation, ma'am, to present today. So yeah, we do have findings.
Summarize or give us some of those findings for the benefit of our members who hasn't read on your findings.
Yes. With regard to the specific issue at hand on the unsettled claims of the HCIs, we already have findings on the actually we audited the turnaround time of the processing of the claims of the PhilHealth. So we in our findings, let me yeah, we found out that more than 50% of the processing of claims of the PhilHealth is beyond the 60-day period. So also we also have these findings on the accounts payable of the PhilHealth, which is really ballooning to huge unsettled amounts. So that is also in addition to our findings on the COVID-19 package. Hello, ma'am.
Yes, yes, please proceed.
Yeah.
Is that all?
We do have findings actually, ma'am. The COVID-19, there's a lot. So I think um, for the specific issue at hand, I think that's the most important one with our findings on the turnaround time, on the delayed. We noted the delayed processing of the claims of PhilHealth.
Sir, did you
Yes.
recommend the pre-audit, medical audit before payment? Nag-recommend po ba ang COA?
Actually, ma'am, I think you are speaking of the medical prepayment review. The medical prepayment review is an internal policy of the PhilHealth. So what our finding is just we didn't recommend to have, to conduct. We are not the one who recommend to have that medical prepayment review because it's actually a policy of the PhilHealth to have that medical prepayment review. So what we just did is we just validate if that medical prepayment review is effective. And we found out in our findings that it's not that effective.
Okay.
And it's already stated in our report, ma'am.
Okay. So hindi nyo talaga directly ni-recommend to conduct pre-audit kasi yun ang minimension ng PhilHealth. And are you aware of the ARTA's recommendation to streamline pre-assessment or prepayment review of the documentary requirements and implementation of post-evaluation audit and automation? Aware po kayo doon sa recommendation ng ARTA to pay yung mga pending claims ng PhilHealth beyond 60 days kasi 60 days supposed to be ang processing time lang nila. So ang recommendation ng ARTA is to pay. So amenable ba kayo doon sa recommendation nila?
Actually, ma'am, we are part of the meeting with ARTA before this meeting.
Yes,
So
yes.
yes, so yes, we are present in that meeting, ma'am. So we agree with the findings of the ARTA, as it's a collective. Yeah.
And their recommendation, you agree with their recommendation also?
Yes, ma'am. We agree with the recommendation, but still subject for our audit.
Okay. So I asked President Geran earlier on the DCPM, is this compliant with auditing rules? Although natanong ko to last time, but you were absent and President Geran said that during the consultation nga you were present and DCPM was also presented with you. So gusto ko lang pong i-clarify, is this compliant with auditing rules? Sir? Sir? From COA, sir?
Hello again, ma'am.
Yes, sir. You're aware with DCPM po?
Yes, ma'am. Yes.
Yes.
The adoption of the PCM.
Yeah. Yes po. Ang question ko po is if this is compliant with the auditing rules.
Yes, ma'am. Actually, ma'am, with the adoption, we recognize and acknowledge the adoption of the DPCM, or which is the debit credit payment method, to expedite the processing of the unsettled bills to HCIs by the PhilHealth. Yeah, it's the adoption itself has the authority. I mean, the PhilHealth is authorized to have that to have that method of processing the claims. But still, as we always emphasize in our letter to PhilHealth, that however, this DPCM is we always emphasize that the realization of this, the benefits of having this new method, the DPCM, it's really dependent on both of the parties. I mean, the efficiency of the hospitals in the submission of the claims to PhilHealth, and also on the part of the PhilHealth in being efficient in the evaluation or processing of the claims. So yeah, we acknowledge the adoption of the new method now.
Okay. So ano sir ang pagkakaiba nitong DCPM at saka ng IRM? Kasi nabasa ko po in your COA findings on the IRM,
Yes.
you're parang disallow that, no? Kasi you're mentioning that you don't allow the prepayment for services haven't
Not yet rendered.
Yeah.
Yes, ma'am.
So ano po ang pagkakaiba nito? Ito po ay, ang IRM actually is pareho lang din po that prepayment, advance payment, actually for the services rendered already. Kasi may mga payables din ang PhilHealth to the hospitals. So ano po ang difference?
Yeah, what is in the IRM, ma'am, it wasn't emphasized that the advance payment is for the unsettled claims. It was just made, or it was just paid as an advance payment, which if we are taking into account the method of the IRM is really a violative of the prescription on payment of advance payment, which is for payment of services not already rendered by the hospitals. But with the adoption of the DPCM, it was already being cleared out, or being emphasized now, that the DPCM is actually a payment of those claims that already rendered, or that already being served by the PhilHealth. So that's the difference between the two, because the DPCM is not really an advance payment per se, because it's really covering existing claims for reimbursements that have been already rendered by the hospitals. In contrast to the first method, which is the IRM.
So policy statement lang ang pinagkaiba, sir, no?
Yes, ma'am. Yes.
Failed to put in the IRM policy yung just what's stated in DCPM. Sir, are
Yes,
you
ma'am.
aware of the global budgets? It's one of the method of advance payments under the UHC law and its IRR.
Yes, ma'am. The global method.
Yeah. So prepayment ito, sir. Even I think in the prepayment, just like in other countries practicing this method of benefit payments, hindi pa na-render ang service dito, sir. So if in the future ang PhilHealth po ay mag-evolve ng methodology, no, from all case rates to global budget, ano ang position po ng COA doon?
Actually, ma'am, that kind of the issue on the global payment method, we do have this differing interpretation between PhilHealth and COA. But I think, ma'am, at this point, I cannot give, in behalf of COA, we cannot conclude at this point as to since it's pending. I mean, it's debatable, and it's we have a different interpretation about that, ma'am. So I think it might preempt our future audit on the matter. So it's better to say,
yeah.
Yeah.
So hindi mo ma-confirm o masagot yung,
yeah, ma'am.
which means may possibility if ang PhilHealth will use that kind of method, disallow ninyo?
Ma'am, it depends on our evaluation and validation on the adoption of the global payment method.
Okay, thank you, sir. Thank
Thank
you.
you, ma'am.
I would like to call on Kong Stella. You have Kong Stella.
Yes, good morning,
Can,
Madam Chair.
yes, you have the floor, Kong.
Yes, well, una sa lahat, Madam Chair, I'd like to thank DOH for their excellent updates. Bigla ako naging hopeful na kaya natin ma-defeat ang COVID. But anyway, so I just have a few clarificatory questions, particularly for Dr. De Guzman. Dr. De Guzman.
Good morning, ma'am, Madam
Yes.
Chair.
So I just want to clarify, yung number of COVID cases. This is still based on the number of PCR tests. Tama po?
Madam Chair. Yes, Madam Chair, we are still reporting based on our RT-PCR positive cases, but internally, Honorable Congresswoman, we're also tracking our antigen, those who test positive or are confirmed cases via antigen line list. However, we'll have to admit our challenges in having our local government units as well as our disease reporting units to consistently report yung mga antigen positive po nila so that we can actually add them and determine ano po yung total case count. Thank you po.
And ito pong adjustment based on, I suppose this is based on the contact tracing being done by the LGUs. Tama po?
The adjustments in our protocol, Madam Chair, you're referring to?
No, the adjustment on the, so you start with the number of PCR positives and then you add to that those antigen positive. And these antigen positive information would come from the LGUs.
Yes, Madam Chair.
Which
However,
comes from contact tracing of the LGUs, etc.
Madam Chair, if I may, not necessarily po, ma'am. So there will be those who are unexposed, but because they became symptomatic or fit our case definition, they sometimes would prefer to undergo antigen test. So meron po tayo mga nag-positive sa antigen na close contact and part of the contact tracing activity. But there are really others po na hindi nga po close contact pero naging symptomatic po.
And dun sa number of COVID cases, ilang porsyento doon yung nanggagaling doon sa adjustment from the antigen test results?
Madam Chair, honestly, that's data that is not available right now. It's one of the fields for our case investigation form. Yun pong tatanungin sila, ikaw ba ay na-expose to confirmed case or suspect po para alam natin.
So in other words, still predominantly the PCR results?
Yes, Madam Chair. It's really predominantly RT-PCR.
Yes. So Dr. De Guzman, would you agree with me that the COVID numbers are really just very understated? Kasi halimbawa po in my household, 11 po kaming members, 5 po kaming nag-positive, but of those 5, 2 lang talaga nag-PCR. So yung, 6 kami nag-positive, 2 lang nag-PCR. So yung 4, hindi na siya nasama sa official statistics ng DOH. So tama po, no? So it's correct to say that the numbers that we're seeing are really severely understated.
Yeah. Madam Chair, actually, yes. And even I think outside our country, it is underreported for several reasons. Number one, nabanggit niya nga po, so pag hindi kayo nagpa-RT-PCR o hindi kayo na antigen, hindi kayo masasama sa bilang. But there are also those who are asymptomatic, unknowingly infected po na hindi kasi natin na-detect. Kaya hindi rin po sila nabibilang doon sa total confirmed cases natin.
So given that merong data imperfections and in many cases malaki yung data imperfection, tama po na napakahirap mag-forecast. Tama po.
It is challenging, Madam Chair, to forecast po. But I think from the end of the Department of Health, maybe baka, Madam Chair, what we'd like to use is to project, no? Kasi dun sa forecast, we just say kung ano nga yung future numbers. But the disease models being used by DOH with FASTER is actually to guide us doon sa gagawin nating polisiya. Halimbawa po, before we declared ECQ, we presented scenarios. So we like to look at trends, and kung based sa trends natin and based on sa differing assumptions and scenarios, which would have the best scenario or the least number of cases and active cases. So we work with imperfect data. But given na imperfect yung data natin, I do believe na it's still reliable enough to guide us doon po sa ginagawa po nating COVID-19 response strategy.
So, maaari ba namin malaman, I think this is the question on everybody's minds. Ano bang projection natin kung kailan bababa? Kasi halimbawa po, in the UK, December 18, they announced the surge.
Yes po.
By January 18, they announced a sharp decline in cases. So nangyari talagang dumami ang nagka-Omicron sa UK, and therefore at a certain point, I suppose because of their natural immunity, talagang nagkaroon ng sharp decline after 4 weeks. But of course, the UK is the UK. Iba ang vaccination rate nila, 80% versus sa atin. Pag tignan natin ang vaccination rate sa total population, that's just 49%. So magkaiba ang situation, but alam natin na kapag magkakaroon ng at a certain point, sharp decline. So may pag-aaral ba kayo nito para naman magka-reassurance naman tayo, no, na we're actually on the right track? And siguro a related question, kasi this morning napansin ko po sa news, nagsabi po ang Okta research that COVID-19 virus spread is already slowing down in Metro Manila. When in fact, when I looked at the figure that you showed earlier, I don't see it's still the slope is still increasing. Of course, nagkaroon ng kaunting in the last day, siguro bumaba ng kaunting yung slope, but predominantly it's still pa ganyan, di ba? Hindi pa siya pa ganon. So, may we know your thoughts on itong pronouncement ng Okta that it's already slowing down? Kasi it would be good to inform our kababayans, di ba? Kasi baka naman maging lax tayo dahil akala natin nagsuslow down na ito na yung makakala natin umabot na tayo dun sa sharp decline na naabutan na rin ng UK. So may we know your thoughts po?
Sige. Thank you, Madam Chair, for that question. I think a week or so ago, the department, through our media fora, relayed po that based on the initial disease models of Pasteur, we may see a peak by the end of January po. But again, we are very cautious in that kasi una po, the assumptions were based on parang initial findings pa lamang on Omicron. So we needed parang more reliable data on how more transmissible it is, on ano po ba yung epekto niya sa vaccine efficacy. And we had to put into consideration how mobile people are and yung epekto po ng MPHS. But those are our initial projections po, Madam Chair. And in relation to that, as to the question that are we already on a decline? Pababa na po ba tayo at nag-peak na po ba tayo? What we're seeing right now is much like what you've observed po, no? The cases are still increasing, but yes, it is slower already. Hindi pa tulad nung una, parang everyday, no, nagdodoble po tayo ng numero natin. Ngayon, nakita natin from cases doubling every day and then every 2 days, it's around 4 days ngayon yung doubling time na nakita po natin, Madam Chair. So, bumabagal pero hindi ibig sabihin nababawasan na po yung dami ng kaso natin. So, it means that we cannot let our guards down. Cases are still increasing, transmission is ongoing, and our second reminder, Madam Chair, is that the case increases we're seeing in the NCR plus areas is already evident in other areas. So we need to prepare ourselves not just for that spike in NCR, but especially in areas outside NCR where vaccination coverage may be lower and health systems capacity may not be as strong or as well established as in the National Capital Region.
Thank you po. And we also have to keep in mind na hindi na rin nagpapa-PCR ang marami. Kasi as soon as you get your symptoms, ina-assume na marami because napakamahal ng PCR testing. Hindi rin, wala rin tayong access. So I think we have to really be cautious about the numbers, di ba? Kaya wag patalos-talos na sinasabing slowing down na because of all of these data imperfections. And But I completely agree with you na it's the right time to shift the policy in reporting case numbers. Dapat mag-focus, hindi na tayo dapat overly focused on the actual number of COVID cases, but of course to report yung severe cases, yung critical cases, and particularly among the subgroup na unvaccinated, para sa mga kababayan natin na hindi pa convinced sa benefits of vaccination, sana mapalitan ng kanilang pag-iisip tungkol dito. My next question is, nabanggit mo nga kanina po yung UK. Sa UK po, meron po silang sistema na the NHS, the National Health Service, would issue certificates of COVID recovery to those individuals na nakapag-recover. And maganda yung instrument na yun because it's sometimes used as a substitute for PCR tests. Kasi halimbawa, when you travel, iba dito kung magsa-travel ka, halimbawa, may mga ilang places like Palawan would require PCR positive. Isang balakid yun sa tourism, di ba? So itong certificate of COVID recovery, maganda sana yan di ba? Especially if it's issued by the government because may natural immunity ka. So ibig sabihin, titingnan mo yun, di ba? Kung valid pa siya in the last 3 months or so, pwede siyang gamitin, di ba? As evidence na meron kang immunity. Is this something that the DOH has looked into? And kasi naiisip ko na baka this is one way na makapag-reopen, we can continue to keep our economy open, particularly sa tourism sector.
Thank you for the question, Madam Chair. You're right po, no? So, after yung initial natin na, di ba po nung una, we required 2 negative RT-PCR tests. The DOH has since shifted even the previous year na there should be no need for a negative RT-PCR test for a person to be declared as recovered, no? And as such fit to work. So, I think in one of our policies po, we did recommend that a certificate from a physician is enough po para makabalik na po sila sa trabaho or para ma-reintegrate po natin sila sa community. Lalo na with these new protocols po na we're actually even recommending no need for RT-PCR if you're mild or asymptomatic or if you're an asymptomatic close contact. They just need to finish the mandated isolation or quarantine period with the with the requirement lang then, Madam Chair, that they did remain asymptomatic or if they became symptomatic, at least clinically recovered na po sila. Those are enough for them to be declared as recovered po.
So, Madam Chair, sa mga kababayan natin na OFW na pauwi na, marami kasi sa kanila na nag-positive tapos nade-delay ang kanilang pag-uwi because hindi sila mag-negative sa PCR because may mga situations ka na may mga remnants pa ang COVID. So it takes a while kahit na you're fully recovered, hindi ka ma-negative. So is this something, itong certificate of COVID recovery, is this something that you can consider for our kababayans na gusto nang umuwi pero hindi na talaga sila makauwi because nga hinihintay nila yung period of time na mag-negative sila sa PCR?
Yes, Madam Chair, this is something we're discussing already po, no? So that it will be applicable not just among the local positives but even for those coming from outside, given that we are requiring a negative pre-departure test prior to arrival po. So we'll update you po, but this has already been raised at the IATF, Madam Chair.
Salamat po. So as soon as you have updates, let us know po. Madam Chair, my next questions are for ASEC Maylene Beltran regarding yung HRH.
ASEC Maylene?
Yes, ma'am. Yes po.
Yan, Madam Chair, salamat din sa very detailed data presentation ni ASEC. I really appreciated that. So, actually, very simple lang yung tanong ko. Kasi sa bawat slide na pinakita ninyo, it's for different types of benefits. So it's possible na halimbawa ko, malagay ako sa first slide sa SRA, pero posible rin na nandun ako sa second slide at saka third slide, di ba? So ang simple question lang is, ano yung unique count of healthcare workers na nakatanggap na ng any kind of allowance relating to COVID? Kasi di ba, there are different kinds of allowances, di ba? So ilan na ang unique count ng nakatanggap ng any kind of allowance? And what's the average amount?
Yes, Kong, thank you very much for that question. We're still checking our data and we're into that. We're working on the numbers para po may unique figure po kami. As of now, I cannot give you a direct answer, Kong, but we're working on that now so that we would know which is that unique benefit which would identify the how many healthcare workers, the number of healthcare workers that have been given. But we are working on that, Kong, in short.
Well, Madam Chair, actually ang concern ko lang naman is ilan pa ang hindi pa nakakatanggap. So, di ba? So, I think yun ang pinaka-important na concern sa ngayon. Although, of course, nakikita natin magaganda yung numbers, no? Pagdating sa SRA, higit sa 400,000. Pero ang tanong, ano ba yung universe, di ba? So, ilan pa yung pinagkakautangan natin na healthcare workers at ano yung time frame natin para kahit paano, no, dapat ang bawat healthcare worker nakatanggap, no, ng any amount of allowance at this point in time. Kasi as you know, pinagtutulungan natin lahat dito na magkaroon kayo ng budget, di ba? Yung dun sa 2022 GAA, and can you also confirm that? Di ba, naging problema natin dun sa NEP, wala kayong nilagay na budget for SRA. Pero nagawa ng paraan ng Kongreso at ng Senado, so nagkaroon kayo ng budget para sa 2022. So that's a related question. So ilan pa ang iniisip ninyong kailangan ninyong bayaran na healthcare workers? Anong time frame natin around that? And pangatlo, ano yung budget natin na na-approve for 2022?
Okay. Kong, just to give you a number, yung kailangan pa ho nating bayaran ngayon, especially for SRA, is around 100, as I presented earlier, it's that figure na 184,799 healthcare workers. Yun yung definite kami na yun yung hindi pa namin nabibigyan for the period December 20 to June 30, 2020 and June 30 to June 30, 2021. But surely some of these have already received some kind of SRA prior to that period. So yun po, Kong, we're working on this 184,799 healthcare workers. And yung related question on the GA 2022, Kong, we thank very much, of course, our House of Rep, kasi nasuportahan ho kami sa pagbibigay, pag-i-include ng 50.4 billion doon po sa GAA 2022 po. And yes po, may amount na ho ngayon doon, 7.9 billion ho yung program funds. And we're working with, actually we've discussed already with DOF and DBM initially on how we can source out the unprogrammed funds of around 42 billion po for the benefits. Yun po, Kong. And again, maraming salamat po to our representatives for fully supporting us in including that amount for the benefits of healthcare workers po, including compensation.
Kailan ang projected release date ng 7.9 billion para agad natin mabayaran itong 184,799? Para agad natin mabayaran itong 184,799.
Kong, medyo choppy ka. You came in choppy a bit.
Ano ang projected release date ng 7.9 billion?
Sa ngayon, Kong, we are, as I've said earlier, we've made representation to DBM on this amount. They will soon be releasing an additional 1.18, and we are also identifying savings from CONAP for the release of this one. And then that's actually the SRA that I'm talking about po. For the 7.9 billion, it's for later release po. And right now, we are preparing the guidelines for the release of this one COVID allowance. to our healthcare workers. So we again talked to DBM on this. Actually, it was just yesterday when we talked with them. And again, it's for later release. And we hope to make things out and really be able to release this very soon.
So, just to clarify, meron kayong 50.4 billion for allowances for frontliners, 7.9 would be programmed, the rest are unprogrammed. Kaya lang,
Yes, ma'am.
dun sa program, the 7.9 billion, ang problema, for late release. In short, wala pa dyan yung pera.
We were informed.
So nasa executive na kung kailan nila i-release yan. Nasa kamay na ng executive kung kailan nila i-release yan. So sige po, update na lang po kami kasi alam naman po natin medyo challenge ang for late release. So nakikiusap po kami sa executive kung sakaling nakikinig po kayo, sana po yung for late release maging early na lang po because kailangan talaga yan ng ating frontliners because they're really very tired at this point in time. We really need to give them all the protection and compensation that they truly deserve. So, salamat po. Madam Chair, my next question is for PhilHealth.
Yes, ma'am. Thank you po.
Ang question ko po sa PhilHealth, Madam Chair, is yung paano ba nangyari na nagkaroon tayo ng policy na whichever is lower? So I'd like to ask about that. Hindi ko po alam, Madam Chair, who the right person to answer the question is. So essentially, yun ang question ko, no? Pwede pang explain sa amin ang nakikita ninyong benefit of this new policy of choosing between a case rate and whichever is lower. So sa ngayon po, since the time that you implemented this policy, ilan sa mga claims paid out, ilang porsyento doon ay lower talaga than the case rate? I understand where you're coming from. Sinasabi ninyo na may mga case rates na masyadong malaki, so overestimated siya. So in the effort nyo na tipirin ang pera, which is also good, kaya lang syempre may disadvantage na it takes a longer time to process the claim. So I'd like to know, ilang porsyento sa claims paid out ang actually ang binayad ninyo is not the case rate but an amount that is lower than the case rate?
Madam Chair, thank you. To the questions of Congressman Stella, the matter of paying whichever is lower between the statement of account, the actual, and the ECR or the case rate is a matter that was brought up in the audit exception of the COA, Madam Chair. So it's a COA exception.
So Madam Chair, may we ask COA to validate that? Talaga po ba, sir, sa COA, is this a recommendation that you made to PhilHealth? Meaning sinabi ninyo, pag dumadating ang claims, i-compute ninyo based on the actual charges and whichever is lower yan ang bayaran ninyo.
COA? Representative from COA? Sir? From COA? Ma'am Sylvia, sino nga yung representative natin from COA?
Si Sir Faisal po.
Sir Faisal. Mr. Faisal from COA.
The issue on overpayment of claims to hospitals, this has been a recurring audit finding of the Commission audit since 2016. And such findings appears the audit report of the COA from 2016 to 2020. We can confirm that we recommend that for statement of account, which is lesser than the applicable case rate, we recommend that it should be paid the lower rate.
So, sir, sana po naiintindihan natin yung rationale behind the case rate. So we have many case rates. We have over 3,000 case rates. So talagang necessarily, some may be higher, but many others are actually lower than actual costs. So, but ang rationale kasi ng case rate is it's a way to encourage efficiency. So tama naman na may problema kapag masyadong mataas yung case rate. Pero hindi ba dapat na yung recommendation is itama ang case rate rather than ipa-compute ninyo kung ano yung fee for service, and if the fee for service is lower than the case rate, fee for service. Kasi ang mangyayari po doon, you miss out naman on the efficiency gains from administering case rates. So, may ganun po hindi po ba? I think the correct recommendation is you review the case rates. Kasi right now, ang case rates is based on the average value of claims. They look at historical average value of claims. They take a percentage of that. Yun ang nilalagay na case rate, which is really not the right way to set case rates. And dapat dyan, you really do a proper costing. Magpapadala ka talaga ng researchers sa mga hospitals. You do a proper costing of the resources required to treat patients for certain cases. That is the correct, tingin ko po bilang isang health economist, yan yung tingin kong correct approach rather than pilitin ang PhilHealth na mag-revert to fee-for-service, because reverting to fee-for-service in a situation where the payment scheme is case rates, talagang you will really unnecessarily cause delays in payment. Is this something po that you had considered?
Sir Faisal, I think kung Stella, nasa recommendation nila yun to conduct parang study or review ng rates ang PhilHealth. So siguro yung PhilHealth dapat talaga pag-aralan na nila yung all case rates kasi kaya umalis tayo sa fee-for-service. Kaya para dumali, no? Ang sabi nga nila, mas konti ang kailangan ng manpower sa rates. Ngayon, lahat naman ay sa hospital mo, parang bumabalik na, okay, magre-recompute again ang hospital. So parang yung hospital, nag-i-implement ng all case rates, and then, in the ground, ang nangyayari, yung hospital, parang nag-fee-for-service sila. They have to compute naman ngayon. So ang hirap on their part. Baka din ang PhilHealth, it's about time na i-review kasi nakita ko sa recommendation ng COA, i-review nila and find out ano talaga yung average payment to hospitals na dapat na nakukuha nila. And tama yung costing talaga properly computed. COA, can you expound more on your recommendation based on that findings? Mr. Faisal?
And Madam Chair, siguro let me just add before si Sir Faisal replies. Hindi ba instead of siguro having 3,000 plus case rates, and it's very difficult to properly set 3,000 plus case rates, hindi ba if we should just concentrate on the 30 case rates, which will anyway account for, I think, 80% of all claims. In short, you identify those cases that will account for a big proportion of your total claims. At doon na lang natin i-effort ng bonggang-bongga ang pag-compute ng proper case rates. And then the rest, baka doon ang pwedeng mag-hybrid, baka pwedeng mag-fee-for-service. But at least you know that for 80%, for the bulk of your cases, properly costed yung case rates. So yun po yung aking recommendation. And anyway, siguro pakinggan na lang natin, Madam Chair, si COA.
Mr. Faisal, then siguro we can ask din PhilHealth ano yung plan nila.
Opo, and Madam Chair, balik ako dun sa question ko earlier. Ilan porsyento yung whichever is lower? Kasi again, based on our previous hearings, alam natin na 22%, yun ang sinasabi ng PhilHealth, 22% daw ang overpayment. in short, these are the case rates na tila napakataas. So since konti lang siya, madaling ma-identify na, di ba? Parang ang hirap naman na mag-implement ng whichever is lower policy across the board, which will unnecessarily cause delays in payments.
Sir Faisal?
Yes, ma'am. Can you hear me, ma'am?
Yes, yes. Please
Yes,
proceed.
sorry, because I'm having a trouble with my internet connection. Actually, ma'am, our recommendation is part of our recommendation is the recommendation of whichever is lower. That is part of our recommendation. But still, the COA also conducted a performance audit report that really reviewed the all case rate system that is also published in our COA website, which include recommendation of the COA also to review the all case rates. We are not recommending to go back to the fee service, but we really acknowledge all case rates, but they have to review the implementation of the all case rate. You are correct, ma'am, with the saying that the PhilHealth has to really review on the all case rate system, particularly in the costing. So what we recommended is the review of the all case rate system, and also to at least to recommend for the meantime also, including also of our recommendation is the considering or the asking the management, the PhilHealth management, to consider our recurring audit recommendation to reevaluate the guidelines on the implementation of the ACR, which is to revisit and by including a provision of the reimbursement shall be based on the member patient's actual hospitalization rate if it is lower than the applicable case rates. So your recommendation, ma'am, is also being considered by Commission on Audit.
And thank you po, Madam Chair, for that clarification. Siguro isa na lang po, no, baka naman is COA open to reviewing the recommendation of that whichever is lower policy, because unfortunately, effectively, you are forcing PhilHealth to actually go back to fee-for-service for those cases. So, baka naman pwede niyo pong i-review ulit ang recommendation na yan. And siguro maganda na rin balikan ulit yung question ko earlier sa PhilHealth, ilan porsyento doon sa lahat ng claims paid out na in-apply nila yung lower fee compared to the case rate, para malaman natin ilang porsyento ba talaga yung overpayments doon sa actually na nagfa-file. And ano ba yon? Ano yung cases ba yon? Kasama po ba dyan ang COVID?
Attorney Garan?
Madam Chair, we will just submit a report on that to the committee, particularly the very good Congressman Stella. But right now, Madam Chair, there has been an ongoing study of the all case rates conducted by the UP Manila. Their preliminary report was made to the EXICOM last December 31, Mr. Chair, Madam Chair.
So offhand, Attorney Yaran, simpleng tanong lang po, no? Kasama ba sa COVID yung lumalabas na overpayments?
Opo, Madam Chair. Kasama po lahat, Madam Chair.
No. Doon sa lumalabas nga na tila in the end, ang binabayad ninyo is yung whichever is lower. Marami po ba dyan na COVID claims?
We cannot ascertain at the moment, Madam Chair, the certainty of how much COVID is, how much involved in the COVID cases.
Sige po, paki-submit na lang po yung data sa as soon as you can po, para we can also make recommendations. And then, Madam Chair, last question na lang po para kay Dr. Cabotaje. Is she still here? Again, just clarification lang po, Madam Chair.
Yes, ma'am, I'm here.
Yeah, Yusek, I just want to clarify, yung eligible population ninyo for 2022 is now everyone. It's now 111 million. Kasi po, as of 2021, ang target population po ninyo or eligible population is 78 million, di ba? Pero napansin ko po doon sa isang
Yes,
slide
ma'am.
ninyo na pagdating ng 2022, it's really everyone na ang nilalagay ninyo sa eligible population. Tama po?
Yes, ma'am. We are recalibrating that and slowly attuning our local chief executives because it's also difficult to all of a sudden they have very high coverage tapos biglang bababa. Yes, ma'am. We are recalibrating. All population na po.
Okay, so sana po magkaroon kayo ng another column sa inyong slides to show kung ano yung coverage rate using the new
Population.
eligible population. Kasi right now, it would seem na, 70% we've achieved herd immunity. But in fact, it's really just 49% using the new definition of eligible population for 2022. Para rin mas, kumbaga, faithful yung ating presentation. Pakita rin natin po. And last question na lang talaga po, Madam Chair. Yung para sa 5 to 11 na bakuna, meron na pong EUA? Meron na pong EUA for
Yes,
that?
ma'am.
Ah,
Pfizer lang po.
okay. So ano ang ating target date para umpisahan ang 5 to 11?
Ang January 31 po ang tentative arrival because we have already reprogrammed some of the adult Pfizer for these children kasi iba po yung formulation. So they're targeting start of February po ng 5 to 11. Basta dumating po yung quantities, it will be in tranches. So ang iniisip po ay yung most populated, kung saan may mga cases. Ganun po tayo mag-start ng 5 to 11, ma'am.
That's very great news, Yusek, para at least magkaroon na rin ng linaw yung ating face-to-face classes. Kasi habang nababakunahan natin ang kabataan, mas nagkakaroon ng possibility na makabalik na tayo sa face-to-face classes. Yun lang po, Madam Chair. Salamat po.
Thank you, Kong Stella. Yusek Mierna, may recent statement si Secretary Galvez that you now allowed the pharmacies to
Yes, ma'am.
give the COVID-19 vaccines. Tama po ba?
Yes, ma'am, Chairperson. We are starting to roll out the strategy. January 20, we had consultations. We will have a few to start with mga 6 to 8 pharmacies. No? January 20, we will have the rollout in identified pilot sites. One from Mercury, from yung mga big stores. And then based on our experiences and our processes, ika-calibrate natin para maka-roll out tayo sa ibang other areas, other drugstores in NCR, and then roll out po natin sa buong Pilipinas.
So, Yusek, ito I will be given free by the government, right? Ang mga pharmacies ba
Yes,
mag-charge?
ma'am.
Are they going to charge admin fee sa DOH?
Yes, we are discussing. It's the administration fee for the patients, the vaccinees, no? So yung mga konting admin, like what we are doing with the private sector for our regular vaccination. We give them the vaccines free, but may konting admin fee. We are negotiating that portion, Madam Chair, but konti lang yan para yung mga processing, etc.
So
pero hindi po yung administration because we give the vaccine, we give the ancillaries, tapos bibigyan din natin sila ng PPEs.
Okay. Yusek, meron kayong sinimplify na policy on the process ng vaccination wherein you remove the BP taking, tama ba? Yung pagkuha ng BPs
yes, ma'am.
From physicians, may mga ganyan kayo na tinanggal to shorten the process. So, pag nag-implement kayo ng vaccination rollout in the pharmacies, do you need the doctor on board? Kasi ang
May screening po.
yeah, so they need doctors on board to screen.
Yes, ma'am. Two ways. Pwedeng pre-screening, bago pa lang pumunta yung vaccine ni Mickey Pila sa drug pharmacy, na-screen na siya, or there is a doctor that will screen, or may self-screening naman, and then we will also, anong tawag dyan, train our paramedical to do some screening, and there will be a doctor that will be available para mga yung adverse event. We are working closely, Madam Chairperson, with our local government unit. Hindi po isolated na pharmacy lang. Kasi yung reporting, tapos yung adverse events, nakalink din po sa LGU where they are located, ma'am.
Okay. So certificate, kung hindi pa na-capacitate ang mga pharmacist natin, so anong klaseng document from a pre-screening ang kailangang ipakita ng isang walk-in individual? Galing sa LGU, MHO, or private institution?
Yes, ma'am.
Okay.
Yes, ma'am. Any of them. Meron na screening checklist kami. Papakita lang na ito okay na siya. Then, they will also ask, may symptoms ba kayo ng COVID? Yun lang naman, anong nararamdaman. That's the simple screening that they will ask. If they already given a medical certificate, on the form, na-fill up na po yung pre-filled form. But based on the rollout that will start on January 20, titignan po natin how the process can be improved better.
Okay. Deputy Speaker Baby Arenas, may question siya dito kung if there is an advisory on booster shots for people that had Sinopharm for the first and second dose.
Unfortunately, we are still studying. Our policy and our experts group are still looking at ano po ang booster sa Sinopharm. There are not enough studies because there is no data available elsewhere abroad and in the country kung ano yung even from Sinopharm, ano ba ang magandang i-booster sa kanya.
So
that we are constantly asking our experts.
Okay, so ano ang advice you, Secmir, na for those who took these shots? Can they have new vaccines in the form of yung mga available right now? Is that still acceptable? Like halimbawa, kung
not yet, ma'am, because we're also asked.
Kung nag-Sinovac siya, then they can have 2 shots of Pfizer. Or kung nag-Sinopharm siya, pwede siyang mag 2 doses of Pfizer. Pwede ba yon?
We have not yet come up with the policy in the next 2 weeks kasi matagal na kaming nagtatanong. There is no data from Sinopharm, even from FDA. So mahirap pong i-recommend kung ano yung ibu-booster. Now, if magpa-primary dose, the experts do not agree. So ang gagawin po ng mga nagkaroon ng Sinopharm, we just ask their patients to wait a little further until we will have a final recommendation po from our experts with the concurrence po ng FDA na pwedeng i-booster ito sa Sinopharm.
Okay. Yusek Mirna, you're part of the IATF, no? Ng NTF, National Task Force.
Yes, I present if I'm requested, ma'am, but there's another group of undersecretaries who stay with the IATF.
Kasi meron akong, we have a representative from the OTR, which I will ask later on yung question ko sa kanila regarding dito sa Novax no ride policy. Gusto ko lang itanong sana kung if the IATF or the NTF were consulted before implementing this kind of policy. Have you heard any discussion during the meeting with NTF or IATF?
I'm sorry, Madam Chair, I have not heard personally, but there were proposals na no box, no ride. But it's really what we heard was the MMDA na ano yan, no box, no entry. Yun lang po ang na-discuss namin sa MMDA, and some of the regions followed suit. But yung no box, no ride, I am not aware, Madam Chairperson.
Okay. Thank you, Yusek Mierna. We have representative from the OTR, no? Yung, I think we have Yusek for a while. Yusek Ochi Tuazon. So gusto ko lang itanong sa kanila if they can enlighten us on the legal basis for the implementation ng no box, no ride policy. Kasi mga constitutional questions on that. OTR. Yes, Kong Kaloy?
With the kind of indulgence of the chair, baka pwedeng bago pupunta kay Yusek Tuason, may follow-up question lang sana ako kay Yusek Kabutahe, if I may be allowed.
Ay, Kong Kaloy, unahin ko lang muna si Rep.
Okay.
Dalia kasi nauna siya.
Okay. Thank you, Madam Chair.
Rep. Dalia, you have the floor.
Good morning.
Sa DOTR. Go ahead.
Good morning, Madam Chair. Maiksi lang to kasi nasagot na lahat itanong na lahat ni Kong Stella yung mga queries ko. Ang concern ko lang sa DOH, nagkaroon ba sila ng maayos na coordination sa DOLE? Kasi ang nagiging problema namin dito ngayon sa baba, kasi may municipality nga kami, alam naman natin na understated yung numbers talaga ng merong COVID. Mas marami pa sa inire-report ng DOH. Problema lang namin sa highly industrialized na mga areas, yung pagbalik ng mga empleyado sa opisina. It seems like iba't iba ang polisiya. Hindi naman, alam naman natin na hindi naman lahat ay nakaka-avail ng RT-PCR at yung iba ay antigen lamang. At sa dami ng kaso, gaya kami dito, Madam Chair, sa amin, nag-average kami ng 60 to 100 per day, unreported pa yung iba. Sana naman magkaroon ng isang maayos na polisiya kasi overwhelmed na kami dito sa kagasagot sa teleconsult, nagpo-profiling, nagbibigay ng medical certificate. Isa pang burden po sa amin yung pabalik-balik na hindi tatanggapin ng employer, hindi tatanggapin ng SSS. Yun lamang, Madam Chair, kasi malaking tulong to sa ating mga kababayan. Thank you, Madam Chair.
Sino pong pwedeng sumagot from the DOH?
Madam Chair, if I may respond po.
Yes, Dr. Helen.
Thank you po, Madam Chair. As I responded po to Congresswoman Stella earlier, the recommendation of the Department of Health, even prior to this change in policy, is to not require a negative RT-PCR after anyone tested positive for COVID po. The move now is the recommendation that a medical certificate will suffice just to attest na other than that person complying with the minimum number of isolation or quarantine, that they are also meeting yung po mga clinical na requirements natin, like dapat asymptomatic na po sila, o kung hindi man po fully asymptomatic, they have already clinically recovered po, so that our employees will not be burdened by the need for a repeat RT-PCR po. Thank you po, Madam Chair.
Ma'am, given po yan. Thank you po sa paglilinaw. Alam na po namin lahat yan. Well, in fact, lahat po kami dito na nagtatrabaho. Ako kasi isang doktor, nagte-teleconsult, tumutulong. Alam namin. Ang gusto lamang sana namin malaman, yung masabihan ng DOH, ang DOLE, na magbigay sila ng maayos na polisiya. Given yan, nababasa yan sa dyaryo, may guidelines kayo. It seems like yung ating Department of Labor and Employment ay hindi masyadong gumagalaw with regards to that. Kasi kung nakakapaglabas yan ng hard and fast rule, guidelines, hindi na po dumadagdag sa burden ng ating pong mga healthcare workers. Sa dami ho na nagpa-positive, yung iba ho nag-home quarantine, natatapos na sila nang umiinom na lang ng self-home remedies. Pero tatakbo yan at tatakbo sa MHO, Municipal Health Office, para humingi po ng ating medical certificate. Sana po naman ito'y mabigyan ng aksyon at ma-call ang attention ng IATF ang ating pong DOLE. Yun lamang po, ma'am. Thank you po.
Doktora Thea, di ba meron kayong guidelines na nilabas for those working in private sectors? Tama ba?
Yes, Madam Chair. Yes, but actually this this policy shift was presented by the department to IATF, and DOLE is present during that meeting po. So they have been notified and was given the opportunity po to raise queries. Secondly, Madam Chair, I'll have to check kung merong specific BM na pang private sector. Right now, the department memo is supposed to be applicable to even beyond dun sa healthcare workers natin sa government. So the assumption is dapat kahit private sector po will be following the same policies. But noted po on the reminder of our Congresswoman, will coordinate po to DOLE. They may already be updating their policy na rin po, Madam Chair, so that they will provide guidance to our employers. Thank you po, Madam Chair.
Dok Teyan, kasi ay yung policy nyo na 7 days, no? Although you mentioned na evidence-based, no? Yung recommendation nyo, basta asymptomatic na sila,
Yes po.
no need for repeat testing, whether antigen or RT-PCR. But we know naman talaga what's happening
Yes po.
in the ground, no? Like for example, sa amin, in our household, yung driver namin, 20 days na siya. 20 days from the time na nag-positive siya, asymptomatic, still positive. And then I asked for the CT value. But so, I don't know. So I asked, ano ba kung ang CT value mo is 28 or 30? Is this infectious pa? But knowing that you have that kind of value at meron ka pang live virus siguro, na nandun, syempre hesitant ka na papasukin yon. Ang protocol nyo, 7 days nga lang Hindi ba yung 7 days and you don't require further testing pa or repeat testing would be a means na talagang wala. Marami na rin na lumabas na infected and followed your protocol and they're spreading the virus to other people also. So hindi ba nakakatakot? I asked na Yusek Verheri on that policy, especially on healthcare workers, no? Although I was informed by some government hospitals and private hospitals that they really implement pa rin ang repeat RT-PCR before returning to work, no? But as stated kanina ng PGH sila, they don't require naman. Although merong mga ilang cases that they require. So yung policy talagang sure tayo na that will be an effective and efficient way para makontrol din natin ang pagkalat or transmission of COVID?
Madam Chair, yes po, no. In fact, our policies are a bit more conservative even what yung pinakikita nga ng CDC po, no? Sila nga po as short as 5 days. Tayo, we had that middle ground. But our recent studies are showing po na kung dati kasi, no, parang until 7th day, we are still infectious, we still have that high viral load. Nakikita natin, once you are fully vaccinated, within 3 days po, no, natatapos yung ating infectious period, no, most of the time. And that's one of the basis why we shortened it to just 7 days. But again, Madam Chair, the caveat is they have to be either asymptomatic or they have already clinically recovered. Kapag hindi po nakasama yun sa requirements, they really need to seek consult of an attending physician just so they can be guided if, pwede na ba ako ma-discharge or itatag po ako as recovered po. But noted, Madam Chair, on the concerns, and I think on the part of the DOH, you just need to keep on disseminating the evidence base for these new protocols po. Thank you, Madam Chair.
Thank you. Kong Kaloy, you have question for Yusek Myrna?
Yes, Madam Chair, Yusek Myrna or from the DOH. Balikan ko lang kaagad yung nabanggit kanina ni Yusek Myrna regarding doon sa possible pag-allow, no, sa mga pharmacists to na maging vaccinator, if that is the right term. Nabanggit kasi niya kanina na merong mga admin charges na kasama, no? Libre yung bakuna pero may sasaguting admin charge. So ito ba ay sasagutin ng DOH or ipapasa ito sa ating mga vaccinees or sa mga mamamayan natin na magpabakuna, Madam Chair?
Madam Chair, may I answer?
Go
Kagaya
ahead.
po ng sinabi ko kanina, pinag-aaralan pa. Some would like to have, para ma-sustain ito, may konting admin charge. Ito po will be borne by the vaccinee. Kasi kung ayaw nilang pumila sa pharmacy, then they can go to the local government unit para totally free. But we're offering some alternative, especially ngayon na ang dami sa ating mga healthcare worker ang nakakasakit, so marami pong nagko-close na vaccination centers, and hopefully hindi masyadong ma-affect ng forthcoming elections, yung mga vaccination. So we are looking at those alternatives. Wala pong definite pinag-uusapan pa, but ito po ay isang release na issue. Maybe for a short term, they can waive the admin charges, but for the long term, baka hindi po kayang i-waive kasi yung mga, ano yung tawag dyan? Salary naman po ng mga magbabakuna, they will be out of their regular jobs, and then hindi naman po pwedeng CSR lang. But pinag-uusapan pa, Madam Chair, Sir Representative Carlo.
Maraming salamat, Madam Chair, Yusek Mirna. I asked that kasi at this point, no, napakalayo pa nga natin sa target nung dapat mabakunahan. No? Wala pang 50%, no, kung pagbabasihan natin yung bagong target natin, no, to cover all our population. So talagang matindi yung hesitance ng mga tao. In fact, tingin natin kailangang i-incentivize yung ating mamamayan para magpabakuna sila, no? Kasi talagang namamayagpag rin yung anti-vaccine narrative ngayon, but in most cases ang ating mga mamamayan, many cases, no? Dahil may attendant expense din yan sa kanila, lalo pa sa ating mga mahihirap na mga kababayan. Kaya tinatanong ko yung kung papasalo natin sa vaccinees, no, at this point, it will in fact add to the, I think, hesitation ng ating mga mamamayan, no? So I hope seriously i-consider yan. If there will be admin charge, I think dapat i-subsidize ng pamahalaan yan rather than ipasa ito doon sa ating mga ordinaryong mamamayan. So yan yung sigurong isang gusto kong i-point dyan, Madam Chair. Next, Madam Chair, ito para lang sa aking kalinawan as a lay person, no, dealing with these medical and health issues. Ang dominant variant ngayon, if I understand it right, is itong Omicron, no, or Omicron variant. Na possibly this, if I'm mistaken, kindly correct me, possibly ito yung reason nung spike, no, nung cases na umabot na ng almost 40,000 in September last year. Yung pinakamataas natin is nasa, I think, 22,000 or 23,000. Ang sabi nila noon, that's the Delta variant. So ang tanong ko lang, Madam Chair, para tanong din ito ng marami, kung itong Omicron na ngayon ang dominant, anong nangyari kay Delta at saka kay Beta? No? Nananahimik na ba sila o nawala na sila? So anong maging dapat attitude natin dito? No? Dahil nitong mga nakaraan kasi, ang daming statements, this is a blessing in disguise, itong Omicron, you are seeing the end of the pandemic, etc., etc. So some people naging lax. No? So it sends a wrong signal, I think, to a lot of people, no, na maging kumpiyansa sila dahil ang Omicron daw is not as matindi compared to Delta, etc. So can we get a reply or clarification from the DOH on this, Madam Chair? From Teka Aleta siguro.
Doktora Thea de Guzman.
Yes, thank you, Madam Chair, and thank you for Rep. So we'd like to clarify that we have declared that Omicron is the predominant variant in the National Capital Region, and that is based po on our latest whole genome sequencing results po, Madam Chair.
Doktora Thea,
yes, Madam Chair.
But outside NCR, especially yung mataas nating cases like Region 3 and Region 4, do you have data?
Yes, we have not yet established, Madam Chair, that it is the predominant variant in the other regions. And in relation to the question of of our honorable representative, we are still detecting other variants of concern, and it's mostly Delta po. So there's still co-circulation of Omicron and Delta. So ano po yung impact nito sa atin, no? So I think much like every time we meet a new variant of concern, ang napapansin naman natin, the impact really is on the large case numbers. But even with Delta, actually we had better utilization rates than in Alpha or Beta po. So it didn't really cause more severe disease. And in Omicron, the impact is it even has less hospitalizations nga po than Delta. So anong gusto nating ipaabot? Number one, the shortened isolation and quarantine protocols were actually made suited to Omicron na at in the context na mataas na nga po yung ating vaccination coverage. But tama po si Representative, it doesn't mean na magiging lax na po tayo. Una, not to be parang a bearer of bad news, but we don't know if Omicron will be the last variant of concern that we will see. We know yung characteristic ng mga variants na to that as more cases appear, there's more chances of it duplicating and mutating. So kaya kahit na konti nga po yung hospitalization, the push is still to reduce our case numbers. So we limit the chance of another mutation, another variant appearing po. So throughout the pandemic, nakita natin kahit anong VOC po ang lumabas, one of the best preventive measures is the minimum public health standards pa rin po. At ikalawa po ay yung pagpapabakuna natin. They really didn't change much kung ano yung ating strategy. But this time, because of of the current profile ng ating ng community na more highly vaccinated, and because of the profile of Omicron na less hospitalizations, yun yung naging pagbabago lang natin, yung sa shorter isolation and quarantine po. Thank you po, Madam Chair.
Thank you, Madam Chair. Thank you, Secretary. Doon nga siguro yung confusion ko at ng marami. Dahil if Delta or the other variants are still around, no? Tapos there's an adjustment in the protocols, even doon sa number of quarantine days, etc., to suit dito sa itong nangyayari ngayon na si Omicron is mild lang yung niya, epekto doon sa tatamaan, especially the vaccinated ones. So yun, no, nagkaroon ng confusion, no, doon sa mga policies na yan. Now this will bring me to the issue nung sinabi ni Yusek Teya, Madam Chair, na ang objective pa rin yun is to reduce the case numbers, no? Not only in NCR but in the other regions by observing the minimum health protocols and magpabakuna. Pero parang nawala rito yung matagal na rin namin sinasabi ito, Madam Chair, no? Na key component sa tingin pa rin namin yung widespread testing, no? We call that free mass testing, but we are not referring to na i-test lahat ang ating mga kababayan, but i-test yung mga vulnerable communities, for example, yung ating mga yung mga vulnerable sectors, no, frontline workers, yung mga empleyado natin, etc. No, so of late, recently, ang sinabi lang ng DOH, nag-shift din sila. I think they are more into sentinel surveillance rather than focusing more on testing our populace. So I think at least to this representation, Madam Chair, hindi rin nito matutugunan yung kasi in other jurisdictions, for example in the US, talagang halos libre yung test, no? Mayroon akong kaibigan na nag-comment na pupunta lang siya sa isang kanto, merong naka-tent doon, libre yung testing. Then you can even email to their mga office ko ano yung result ng iyong test. No, i-email sa iyo afterwards. So why is that change in our dati kasi ang sinabi ng DOH anong term nila noon, no? Parang expanded testing. I don't know if that's the term, no? Pero ngayon parang may pagbabago, no? Dahil sinabi nila walang pondo for testing or massive testing free to our people. May we get a reply from Yusek Atea, Madam Chair?
Madam Chair. Ano, Rep, I'm only OIC Director. Rep, not USEC po. In response
Sorry.
po to testing, Mr. Chair, the updated protocols is in the context na nagsaspike po tayo ng kaso. Hindi po siya permanent. We will still review kung halimbawa pababa na po yung kaso natin, what will be the most appropriate testing strategy po. Pero ngayon, ang nakikita kasi natin, given that we are seeing this large increases in cases, and considering na more than 80% of our cases are the mild and asymptomatic, it will be really more efficient that rather than these mild, asymptomatic, non-vulnerable sectors lining up, getting themselves tested, ang pinaka-priority is makapag-isolate na po sila agad, no? And then they can avail of testing later on. But you're right, Madam Chair, we still need to test the priority sector, and our healthcare workers is part of that. Kasama din po doon sa mga priority sectors natin ay ang ating mga A2 and A3. At sila po ay tinetest natin, healthcare workers, kasi gusto nating maprotektahan. Alam natin sila yung backbone ng healthcare system natin. At para sa A2 and A3, napakahalaga pa rin po ng pagpapatest kasi sila po yung sector na baka mayroong pagbabago sa clinical manage na ibinibigay sa kanila, no? Lalo na pag nalaman natin kung confirmed COVID ba sila or hindi. Meron tayong mga bagong gamot na pwedeng ibigay kapag napag-alaman natin na kung sila po ay confirmed cases. So we're not really saying na hindi tayo ay mas nagiging rational lang siguro, no, sa paggamit ng ating testing. Kaya natin binago yung protocols po natin. But still, it's risk-based, it's targeted, and we want to be and we want to prioritize this vulnerable sector po. Thank you po, Madam Chair.
Thank you, Madam Chair. Thank you, Director Thea. Incidentally, may I know, Madam Chair, ano na ba yung capacity natin ngayon to conduct tests? Kasi last year, ang target talaga ng IATF, given the DOH, is to conduct at least maximum 90,000 to 100,000 testing a day. No? May I know, as we speak now, ano na yung capacity natin to test for COVID-19, Madam Chair?
Madam Chair, if I may, Congressman, I'll get back to you on that kung ano po yung ngayon na testing capacity natin. But you're right po, no? During that peak in September, we were actually able to test 92,000 per day po at the national level. Ngayon po, nitong nakaraang linggo, I think we were averaging around 75,000 pa lamang po, no? Tests per day, and I think 46,000 of that is in the national capital region po. So yun po yung ibig namin sabihin na we still have that reserve. Kaya lang, kung mapapansin niyo po, the bulk of the cases are still in the NCR plus areas. Kaya po pag nagsabay-sabay yung lahat ng regions natin, it might be additional burden. Yan yung tinitingnan natin kung kaya niya nga po yung testing capacity natin. And I'll submit to the COMSEC po yung testing capacity natin. I'll just get that. Thank you.
And possibly, paki-detail na rin kasi itong nabanggit mo na 75,000 tests and 46,000 testing sa National Capital Region. RT-PCR test lang ito or?
Yes, Mr. Chair. Yes, Madam.
RT-PCR test.
Yes, these are just RT-PCR.
So in fact, pag mabigyan na rin tayo ng update, during the last week's meeting, there was already a statement na talagang kinoconsider na nating isama sa bilang yung antigen test. No? Dahil kung itong nire-report natin ngayon na daily results, umaabot yung peak niya almost nasa 39,000, 004 nitong nakaraang araw, RT-PCR yon. And I presume mas marami siguro ang nag-avail ng antigen dahil mas mura ito. So that is not the real picture of infected individuals in our country today kasi naka-base lang yun sa RT-PCR. So baka pwedeng madetalye na rin sa atin. And finally, to my last question, Madam Chair, on this issue, there was a commitment last week from PhilHealth, no, na isasama nila sa other matters nila when they met yung inclusion ng antigen test sa coverage ng PhilHealth. May we get an update from PhilHealth, from President Geran, if this is already included sa coverage nila or napag-usapan ba ito sa board ng PhilHealth last week, Madam Chair?
Attorney Geran?
Madam Chair, thank you. Thank you for the question. Madam Chair, can we recognize Dr. Clem Bautista for that?
Doktora Clemen Bautista.
Good morning.
Paki-off po yung ibang gadget nag-e-echo.
Madam Chair,
Okay, go ahead.
it's true po, it was presented during the last board meeting. And at that time po, we were asked to provide po additional information, especially in terms of its budget impact, and for which we need po, we are currently gathering data, especially on the epidemiological data on this, and also of course that's together with the costing. So once we are done with this staff work, we will present it to the board in its hopefully in its next meeting on the 26th of this month.
So thank you, Madam Chair. So
Thank you,
wala pang decision yung PhilHealth Board. I hope ma-fast track nila ito dahil ito yung pinakamura ngayon na pamamaraan ng ating mga kababayan to avail of the antigen test to confirm whether they're infected or not. So ini-emphasize lang natin yung kahalagahan na pabilisin din ang desisyon nito ng PhilHealth. Yun lang muna siguro, Madam Chair. Thank you for accommodating my questions.
Thank you, Kongkaloy. I have a pending question to our representative from the OTR.
Good afternoon, Madam Chair.
Yes, sir.
Insect Watson from the DOTR.
Yes,
If I understand the question earlier, Madam Chair, the first question is what was the legal basis for our issuance of the department order? Yes, Madam Chair. As you're well aware of, Madam Chair, about 2 weeks ago, the MMC, the Metro Manila Council, issued their resolution limiting the movement of unvaccinated persons outside their residences as well as the use of public transport. Recently, Madam Chair, naglabas na po ang DOJ ng opinion nila na sinasabi that the said resolution by the MMC is actually a valid exercise of their police power as granted by the local government code. So pursuant to this, the individual LGUs po ng NCR ay naglabas na rin po ng kanya-kanyang mga ordinansa para ipatupad po itong polisiyang to. Ngayon, yung department order po ng Department of Transportation ay implementasyon lang po ng mga ordinansa ng bawat LGU within the NCR, ma'am. It is an implementation of their ordinances and of the limitation of the movement of unvaccinated persons.
So, Yusek, every LGUs of the NCR has that policy or ordinance all over NCR and you are implementing it.
Tama po yan, Madam Chair. Yung pong 16 na syudad at isang munisipalidad ng NCR po ay naglabas na po ng kanya-kanyang mga ordinansa to this effect.
Okay. I hope i-evaluate then as you implement yung policy. Kasi just like yesterday, I think I read yung sentiment of one of the driver na meron naman siyang initial vaccine, no? Hindi pa lang niya na-complete because waiting for the schedule of the second dose. So kung ang impact kasi doon sa ating mga kababayan na nasa public transport like drivers, jeepney drivers na yan, nakasama din sila doon sa implementation. So nabanggit nga niya, yun ang kanyang pinagkukuhaan ng pangkabuhayan and force siya not to work because of that policy. So I hope tama yung polisiya ng ating mga LGUs kasi meron ding clamor on mandatory vaccination, no? Tinitingnan natin kung yun bang sitwasyon na meron tayo is enough na to exercise that police power. So na-surprise din ako. Well, DOJ is an expert government agency on that matter, but sana pag-aralan din as you go along with the implementation, ano talaga ang magiging malaking impact nito on our general population, especially public transportation po ito no? Kawawa naman yung ating mga kababayan na the only means of transportation is yung public. Wala silang sariling sasakyan, di ba? So, kawawa sila. Yusek, sana pag-aralan pa rin.
Madam Chair, kung pwede ko lang po sanang mabanggit, Madam Chair. Ang isa sa mga layunin talaga nitong ating DO NATO ay para po sa kalusugan ng bawat mamamayan natin at saka ng mga mananakay. Ang DOTR po, in the law that was promulgated creating the DOTR, was mandated to provide safe public transport service po. Ito po yung iniingatan natin din dito sa paglalabas nitong department order na to. Kung matatandaan po natin yung nabanggit kanina po ng Department of Health, yung ating mga datos regarding sa unvaccinated po, nakikita po natin na napakataas po yung mga nauospital po na mga tao na unvaccinated po, pati po yung mga percentage ng mamatay. Yun po ang iniiwasan po namin sa DOTR, na ang public transportation po ay maging vector ng transmission po ng COVID. If you will remember, a few months back, Madam Chair, yung MRT natin po.
But Yusek, yung policy itself kasi, that's unfair for those naman nga na walang means kundi public transportation. Paano yung mga individuals who have that private vehicles, no, but unvaccinated can also a means of pagkalat ng ating virus. So parang kung titingnan mo, may discrimination talaga sa kanila. And alam natin na yung sumasakay sa public transport, ito yung mga nasa ating mga workers in the government, middle income to low income bracket natin, no? So pag tingnan mo, di parang ewan ko sa Metro Manila Council, they have to look into that policy. In general, bawalan na natin lahat ng unvaccinated yata na lumabas, 'di ba? Para pantay-pantay po ang pagtingin. Kung ganoon ang polisiya. So ang tanong naman sa Metro Manila Council, I hope DOTR ask them then, ano ang ino-offer nilang alternative? Kung hindi public transportation ang gagamitin, doon sa mga unvaccinated, especially they said naman na may exemption, tama ba? There's an exemption to the policy. Can you cite some of the exemptions?
Dalawa po yung basic exemptions natin doon, Madam Chairperson. Ang una po ay yung mga medically incapable of being vaccinated po. Kailangan lang po nilang ipakita yung kanilang medical certificate stating na hindi po sila pwedeng mabakunahan. Pangalawa naman po ay yung mga lumalabas po for basic essential like yung food, tsaka yung essential services natin, yung pagpunta sa doktor, yung pagpunta sa trabaho po is considered an essential travel, yung pagbili po ng pagkain, ng tubig, yung mga ganun po. Yun po ang mga exempted po natin.
Okay, so yung nabasa ko po kasi, sumakay siya sa jeep, unvaccinated, and the jeepney driver is vaccinated 1 dose. Pero kung sabihin ko lang, I'll just buy food, so okay na siyang sumakay.
Opo, kasi essential po yun. It's considered an essential travel po.
So pwede rin siyang alibi of all the people, no? Punta lang po sa labas, bibili lang po ako ng pagkain pero mamamasyal pala sa mall.
So, Madam Chairperson, bago po makarating sa public transportation po yun, ay yung LGU rin po ay sinasala po yung mga taong lumalabas kasi nga po sa kanilang ordinansa ay bawal po lumabas ang non-essential travelers po.
Okay, sige. Meron pa pong gusto magtanong sa ating mga members on doon sa concern natin sa no vax, no ride policy? Any members? Okay, balikan ko lang po si Doc Thea, Director Thea de Guzman. You mentioned kanina based on your Doc Thea, na-mention mo kanina yung mortalities natin, deaths in the NCR ay nag-decline talaga, no? And you mentioned that this is due to high vaccination rates. So just wanna ask, what makes you conclude that it is because of high vaccination rate and not because of a better health services in NCR compared to other areas of the country? Kasi alam naman natin, factor yon, no? Mas accessible ang doctor, mas accessible ang healthcare facilities compared doon sa mga probinsya natin. Go ahead, Director Thea.
Thank you, Madam Chair. Madam Chair, I'll make my statement more specific po, no? That the decline in both the case fatality rates and total number of deaths in the National Capital Region were contributed to by, yes, primarily vaccination coverage. But I do agree, kasama po doon sa mga factors which contributed to this lower rates are also, number one, you have better clinical management. Ikalawa, we assume that there's also better health-seeking behavior po, no, from our populace. And you're right po, no, it's also being influenced by better health systems capacity and referral systems in the National Capital Region. And these factors, we also want to ensure na present din po siya outside of the National Capital Region, especially those which have lower vaccination coverages. Thank you, Madam Chair.
Thank you. Any other concern po from the members? Okay. From the DOH, do we have representative from the pharmaceutical division?
Yes, Madam Chair. This is Dr. Melissa Guerrero, ma'am.
Yeah, you were raising some issues on the EUA of some drugs under the Bayanihan law. Go ahead, Doktora
Yes,
Guerrero.
Madam Chair. So we would just like to raise the possible concern on the access to the drugs under emergency use authorization of the FDA. If you remember po, Madam Chair, the Congress gave the HTAC authority to recommend drugs and vaccines that are undergoing clinical trials, so we can look at the interim phase 3. So that's what's happening with the vaccines. So HTAC is recommending vaccines for wide use, hinge on the EUA of the FDA. But we have the COVID-19 Vaccination Act. Now po, yung with regard to the drugs, naka-anchor po yun sa Bayanihan Act, which expired. So now we are asking whether we are authorized to still make a recommendation on the drugs that are being authorized by FDA with an emergency use authorization, given that nag-expire na nga po ang ating Bayanihan Act.
Okay. Well, Doc Guerrero, hindi ba yung HTAC, when we created it, nasa UHC law naman siya, and hindi ba kasama sa functions niya yung in times of emergency?
In the Universal Healthcare Law, there is no consideration for public health emergencies, ma'am. Thus, we had a provision under the Bayanihan and the COVID-19 Vaccination Act na they are authorized to make a recommendation looking at interim trials. Doon po sa Universal Healthcare Act po kasi, kailangan po may phase 4 yung gamot or the vaccine before they make a recommendation for.
But doon sa COVID Vaccination Act, specifically, nilagay natin until merong pandemic.
Yes po, that is for vaccine. So there's no problem with the vaccination, ma'am.
So
our question now is the drugs. Yes, ma'am.
Okay, we'll take a look at that, Doc Melissa. Thank you so much for sharing that. Any other members? Last question na lang kay ASEC Mylene regarding doon sa deployment program ninyo. ASEC Mylene? I don't know if you're the right person to answer my query. ASEC Mylene?
Yes, ma'am.
ASEC?
Ma'am, hindi ho namin narinig yung question.
Oo, this is regarding on ASEC Mylene. Regarding sa deployment program natin, so hindi pa na-renew yung ating mga health workers under the deployment program. So ngayon, ang problem natin with the vaccinations of different LGUs, heavily reliant sila doon sa health workers under your program, no? So how fast can we renew their contract?
Ma'am, if we're referring, good afternoon po, if we're referring to the HRH deployment, like doctors, nurses, ma'am, nandyan si Director Pretzel Tolentino of the Health Human Resource Development Bureau, who can be the more appropriate person to answer po.
Director Tolentino.
Thank you po.
Director Tolentino.
Good morning. For our deployment program po, Madam Chair, tuloy-tuloy po yung ating deployment program and we already have released the allocation slots. Pero ito pong aming deployment program ay another program po siya bukod po doon sa ating emergency hiring. Ito po yung ating mga dinedeploy sa mga primary care facilities natin such as rural health units and barangay health stations.
So
Ito po
na-renew na,
nurses and midwives po natin.
Director, na-renew na sila effective January?
Yes po, yes po.
May mga nag-i-inquire sa akin na municipal health officers about that. Baka hindi siya all over the Philippines implemented.
Meron po kaming proposed na number. Lahat po na 25,000 po na deployed natin ay marirenew po. Ito po kasi yung budget na ni-request namin na additional sa budget pero nailagay po sa MPBF. But we are now writing, nagko-communicate na po kami sa mga regions that they can now renew all their deployed HRH. Na-approve naman po sa MPBF. Gagawin na lang po namin ay i-front load po namin yung budget para ma-hire po, ma-renew po lahat ng ating deployed HRH. So we are coordinating na po to all our regions.
Thank you, Director Tolentino. What about the emergency hiring in relation to this pandemic? Yung emergency hiring natin, na-renew na din sila?
Yung yes, po emergency hiring is ASEC Beltran po. Thank you po.
ASEC Mylene, go ahead.
Yes, ma'am. Yes, ma'am. Regarding our emergency hiring for COVID response, we already have, as I reported earlier, ma'am, we already have rehired 57% of the approved slots po. So ongoing pa ho yung request ng ating mga operating units and we will be more than happy to assess the request and if reviewed, then we will be able to rehire po.
Okay. Thank you, ASEC.
Thank you po.
You mentioned kanina yung FLR for our benefits, no? SRA ba yan? Naka-FLR siya. Kasi nandito ang DBM. We have representative from the DBM. May we ask
yes,
DBM?
Ma'am, correct. Yes, ma'am. I-correct ko lang po. Ma'am, yung ating budget for 2022 will be for one COVID allowance po. So no delineation na po, ma'am, for our proposal and for GA now, one COVID allowance po.
And but then one COVID allowance is naka-FLR ang status.
Yes, ma'am.
Okay. May we ask DBM?
Yes, ma'am. Good afternoon po, ma'am.
Ma'am Jane.
Yes, ma'am.
Happy
Good
New
afternoon
Year.
po. Happy New Year po, ma'am. Glad to hear from you again, ma'am.
Opo. Ma'am Jane, kumusta po yung yung mga FLR status like eto nga pong benefits of our health workers under one COVID allowance na ang item ng DOH.
Ma'am, actually, ma'am, meron po kasi tayong special provision dyan po, di ba? Dun sa 7.9, which is special provision number, ano po siya ata? 14? Or kung hindi ako nagkakamali, ma'am, ha? Kasabi kasi ho dyan, ma'am, kailangan po ng guidelines po na gagawin ng DBM at saka DOH.
Okay.
So, kailangan po natin yan bago ho tayo makapag-release.
So how fast can you do the guidelines? Baka ito na naman ang magiging
Actually, ma'am, yesterday, nag-call na ho ng meeting si DOH. Dinescuss na ho nila yung initial draft nila on the guidelines po. Ang present ho doon, DBM was also present during the meeting. So nag-ano na ho sila. Meron lang ho mga konting mga editing. So depende ho yan sa DOH kung kailan ho nila ibabalik sa amin for our comments, for final comments and the finalization itself of the guidelines.
Okay. Sige. Thank you, Ma'am Jane.
Yes, ma'am.
Maraming
Thank you rin,
salamat.
ma'am.
Ibilisan na lang natin, no?
Opo.
Okay, thank you so much. Kung wala na pong concern ng our members or our guests, maraming salamat po again sa oras ng ating mga kasama sa committee and our colleagues. Kong Kaloy, do you still have some issues to raise?
Wala na muna, Madam Chair.
Okay, thank you so much. Maraming salamat po sa ating mga resource person sa inyo pong palagi ang pagsuporta sa aming committee hearings. May we hear the favorite...
I move to adjourn, Madam Chair.
I second, Madam Chair.
Thank you, our favorite motion. Maraming salamat po sa inyong lahat.
Thank you.
There's a motion to adjourn this meeting. Julie second. I'm sure walang mag-o-object.
Thank you, ma'am.
Is now adjourned. Maraming salamat po. Ingat po tayong lahat.
Thank you.
Ma'am, stay safe.